So we are live now.
We are live now. Start.
Thank you. So good evening, everyone. On behalf of Inasl, I welcome you all to this 28th annual scientific meeting of our Indian National Association for Study of Liver. So when we had conceived this, we thought this year we would be able to do a hybrid meeting. But I think the second wave hit us so hard that we gave up that idea. And so here we are only in a virtual mode, but thankfully at least we are able to do it. And this year we have a heady mix of some very important and contemporary topics in hepatology, and we have great speakers and great faculty to discuss these issues with us. And today we have a very packed back-to-back program. So without wasting much time, I'll request Dr. P.N. Rao, who's the current president of Inasl, and also my co-program director to start the proceedings. Dr. Rao, please.
Thank you, Dr. Kaushal. Welcome you all for Inasl 2021 virtual. As you said, we expected the other way around, but still we have to go with the such thing only. And we have Dr. Kaushal and myself, we have laid out the very day-to-day hepatology program, as you can see, which you face day-to-day. And for this, we have got a distinguished speakers and distinguished chairpersons. And I welcome Dr. Raju Jalan from UK, Dr. Rajinder Reddy from USA, Dr. Shalimar from All India Institute of Medical Sciences, Dr. Pankaj Puri, Dr. Akim Mahimwal, ILBS, and Professor Sareen will be joining slightly late. And also welcome the chairpersons. With this, we will start the first session of the PG course. May I request Professor Chawla to take over and start the first PG course. Dr. Chawla, please.
Sir, you are muted.
Okay. Thank you, Dr. Rao. Thank you, Kaushal, for having a very interesting program. To speak to us for the first talk, it's Professor Rajiv Jalan, whom you all know. He's the professor of hepatology affiliated to the Institute of Digestive Health, UCL Medical School at London. He's done some remarkable work initially in TIPS and hepatic encephalopathy. He moved on to ACLF, acute and chronic liver failure, and he was the first person who introduced this terminology to the hepatologists. So he's going to talk to us on 3 phases of ACLF, how to make the correct diagnosis in real life. Rajiv, please.
So Yogesh, Kaushal, and Dr. Rao, thank you so much for this very kind invitation. And as I said, when I was starting speaking with you earlier, I wish that I was there, but it is what it is. And I just share my issues that all of us have walked through the last 18 months. And I'm really glad to see that we are all here together again. And it really is a great pleasure for me to be here and to be talking to you today. So when Kaushal asked me to talk about the 3 faces, I was thinking about Brahma, Vishnu, and Mahesh. And so I said, so today, what am I? Am I a Brahma, I'm a Vishnu, or I'm the destroyer, Shiva? So you'll see probably faces of all 3 in my discussion today. So here are my conflicts of interest, which are none of which are relevant, but all directed towards various treatments that we're trying to build. So when you asked me to do this talk, I was actually thinking about what it is, why is it that we need to agree on a single paradigm? And it's not for what Europeans think or the Asians think, but it's because of here. It is about our patients. And what is it that we have to do in order to get the best results for our patients? And I express my bias because I'm closest to the European data, which is what I'll be talking about the most. And I hope that I'll be able to convince you that it's the best validated system. I'll start with a case, and because it's sort of in the interest of the topic. So David is a very common patient. So he's got cirrhosis due to alcohol, but he's relatively well. He works normally in the clinic. He's got compensated cirrhosis, comes to the hospital with an episode of pneumonia. He's got a bilirubin of 5. He's got a small amount of ascites. This is the syndrome that we call acute decompensation as a result of a bacterial infection. Over the next 5 days, he develops more severe coagulopathy. He becomes jaundice, grade 3 hepatic encephalopathy, and progresses to even more severe forms of multi-organ failure and dies. And this is a 10-day journey for David in the hospital, having been relatively well previously. So it is this patient that we're going to talk about a little bit in relation to the 3 phases, which I interpret as being European, Asian, and American. As you can see here, if you use the Inasl definition for when he develops acute on chronic liver, he develops 3 organ dysfunction, he would be thought to have ACLF. And using the Inasl system, he would not have a ACLF when he is in the intensive care unit with multiple organ dysfunction, because he has bacterial infection. And so therefore he would not be classified according to that definition. And when he has got these 3 organ dysfunction with coagulopathy, high bilirubin, and encephalopathy, he would not be classified as having ACLF according to Inasl. So classification sensitivity is important because of everything else that I'm going to tell you. I'm not going to spend a huge amount of time on this, but except to say that these criteria that you see here were developed agnostically. So we didn't go to look for defining it based upon these organ dysfunction. It was based upon a study in 1,400 patients, which we were only looking to classify a group of patients that would have a mortality, 28-day mortality of over 15%. So if you set that threshold to 30%, then this will change. If you set this threshold to 80%, these criteria would change. What we took into account was that here is 15 to 25% 28-day mortality was ACLF1, 30 to 40% mortality was ACLF2, and ACLF3 was these patients with a mortality in 28 days over 80%. So therefore, what it allows you to do is to diagnose ACLF in a large proportion of patients, but allows you to categorize the risk of death, short-term risk of death, into 20 to 30, 15 to 25%, 25 to 40%, and over 40%. So it is a carefully calibrated system. So not all patients with ACLF, according to the European definition, would have a high mortality, which is really important to understand. The second point is here, and this is really important, as I'll illustrate to you as we move forward, that it's a dynamic syndrome. It is not fixed. That is, patients can move from ACLF1 to 2 to 3. And during the first 7 days, whichever way they move, the risk of death goes down. If they go from ACLF1 to 0 or ACLF1 to ACLF3 to 0, the risk of death is very low. If, on the other hand, if you progress from ACLF1 to 3, the risk of death follows that particular paradigm, which is true of a clinical scenario. It tells you that your mortality is not fixed. It is dependent upon your response to the intervention. So these are 2 very important, crucial elements, that how the patient comes in is not what the patient will remain as you. And you should be able to upgrade the risk of death of this patient as you move forward. So it's dynamic and it's reversible. The reversibility means that the patient will have survival like that of no ACLF patient, 5 to 7%, if you can convert this patient here with ACLF3 back down to no ACLF. It is very important to put this prognosis into context. So when the patient is admitted to the hospital, he does not have ACLF because he did not have any of the organ dysfunction that I described to you. And his risk of death is categorized 28 days and 3 months using the Cliff AD score. Okay, so I can tell you that 28 days, his risk of dying is 7% when he comes into the hospital. But when he is in the hospital with multiple organ dysfunction, goes to the intensive care unit, At that time, his risk of death increases to 49% because he has got acute on chronic liver failure. So that is this dynamic nature of the syndrome. So it's not a fixed problem, doesn't come in with ACLF, develops ACLF while he's in the hospital. So we didn't do very well by him. This is the CLIF-C ACLF score. So remember, it's a dynamic syndrome. The second point I want to make is, this is just to tell you that bacterial infection is the commonest precipitating event for acute decompensation and for ACLF. In the PREDICT study, we think 50% of the patients that we see have bacterial infection. So therefore, the PASL system where they exclude patients with bacterial infection, you need to think about it very carefully, because you rule out 50% patients that have got, that are presenting to you in the hospital. It's an artificial situation. The second thing that a PASL excludes is patients with decompensation. As you can see here, there's really no difference in the occurrence of ACLF or mortality, whether they have prior decompensation or not, at least in the short term, 28 days. No difference in whether they've got previous decompensation or not. So we need to get rid of whether or not they have previous decompensation or not from our definitions as we consider them. The second important thing to understand is that whatever criteria, whatever face you want to show, you've got to go around the world and test it across the board. So, and this is what we did here. So this is a paper which we published last year, where we looked at data from Europe, from Asia, from US and Latin America. And as you can see, the prevalence on all these studies across the world using the CLIF criteria is pretty much similar. The 28-day mortality is very much similar. 90-day mortality is very similar. If we don't have ACLF, mortality is very low. There are about 10,000 patients, 100,000 patients in this data. So validation, so we are judged by our peers. We have to understand that. And I don't have time to go into the individual data, but in a patient with acute decompensation, it is not whether they have ACLF or not that determines the outcome. They can be divided into 6 phenotypes. So here are the ACLF 1, 2, and 3, and we're looking at the risk of death over a year. Here is a patient with SDC, stable decompensated cirrhosis, unstable decompensated cirrhosis, and pre-ACLF. So in a patient with decompensated cirrhosis, you can have 6 phenotypes. It is not ACLF yes or no that will determine what is going to happen to your patient. So really important to realize it's not the 3 phases, it's the 6 phases of acutely decompensated cirrhosis, as opposed to Asia, Europe, and these are clinical data, large numbers of patients. So coming to the question that Kaushal asked me is, what is a David's correct diagnosis of admission when he's admitted at day 5 and day 10? And I think that it is important to understand that there isn't a single phase. It's a multimodal dynamic diagnosis. So what you have here is David. At hospitalization, he does not have ACLF. His predisposition is alcoholic cirrhosis. His precipitating illness is pneumonia. His response is a leukocytosis, has no organ failure when he presents, develops 3 organ failure at day 5, develops 4 organ failure at day 10, and then dies. So therefore, at the beginning, I think we all agree that he does not have ACLF. By day 5 in Europe, we think he's got ACLF 3. He's got grade 3 ACLF, the risk of death of 60%. Whereas in Asia, we don't think that he's got ACLF because he's got bacterial infection as a precipitating illness. Here, if you think about at the end, I think Europe and Asia, US agree, but Asia, you cannot diagnose him at ACLF because his precipitating illness was something else. The question is, why is it that we now need to change? And I think the answer is starting to be defined. Number one is this is a disease that carries 30% mortality. 1 million people, 1.2 million people are dying from this syndrome each year around the world. If we agree that to solve this problem, we can solve it because there are going to be many treatments that we can test if we have a hypothesis. And I can just show you, I can tell you that at the moment, there are 13 companies that are following new treatments for this condition to prevent its occurrence and its treatment. So there's a big imperative that we provide them the right patients categorized in the right way. Because if you don't, we'll get the wrong answer. And the wrong answer is exhibited here. This is the GCSF study, the famous study from Professor Sarin's group, which changed practice around the world, except that when it was tested in Europe using a very carefully constructed criteria, there's no significant difference in survival with GCSF. As you can see here in ACLF patients, what Shiv and his group showed very eloquently was a very marked reduction in death rates. No significant difference when you use carefully constructed criteria in multiple settings. So it is up to us to provide a background that we can change the outcome of these patients. Why else do we need to change is exhibited here. That is, we have now got recommendations in the UK and Spain that we can attribute priority for transplantation for patients with ACLF. And many of you are participating in this study across the world where we are doing a prospective study to validate whether or not we can make a difference to the outcome of these patients. So selection for transplantation saves lives. And the ACLF criteria, as it is in Europe, is probably leading in that field. In patients that are intensive care going nowhere, you can switch them off if their CLIF ACLF score at day 6 to 7 is greater than 70. And this is really important for resources and for resource management. And I just conclude, therefore, by saying that, the CLIF definition models have been validated worldwide. Previous decompensation and infection are important components. Systemic inflammation underlies the pathophysiologic mechanisms, and we can address it. We have new treatments. Liver transplantation is here now. And if we do not come to quick agreement about what constitutes ACLF, these patients will not have priority for transplantation, certainly in the West, where we do not have living donor transplantation. In the UK, in the Spain, this has now been recommended that these patients will have priority. So with talking about the 3 faces, so I don't know which face you're wearing today. Are you Brahma, Vishnu, or Mahesh? So thank you very much.
Thank you, Rajiv, for an excellent presentation. I would now request Dr. Anup to introduce the second speaker. We'll have the questions in the end, Rajiv.
Thank you. Thank you.
So at the outset, I would like to thank Dr. Kaushal Madan and Dr. Rao for giving me this opportunity to participate in this important meeting. And the next speaker in this session is another very eminent personality, Dr. K.R. Reddy. He is Rumi Family President's Distinguished Professor of Medicine and Professor of Medicine and Surgery in the Division of Gastroenterology Hepatology at the University of Pennsylvania. He is the Director of Hepatology, Medical Director of Liver Transplantation, and the Director of Viral Hepatitis Center. So he will be speaking on reactivation of hepatitis B. So over to Dr. Reddy.
Well, thanks very much for this generous introduction. And I want to thank Inasl again for having me out here. I wish it was in person. Hopefully next year we can meet in person. So these are my financial disclosures. So let's have an overview of hepatitis B reactivation. It's a clinical syndrome. It's characterized by an increase in viral DNA, transaminases, and it can range from an asymptomatic state to a florid state of liver failure. It can occur in surface antigen positive patients and also those who have resolved or so-called occult infection where there's an isolated anticore. Now, this can be seen in the context of many immunosuppressive agents, and I'll impress upon you some of the newer agents that are coming out. It's been seen after DAA therapy in hepatitis C situation. HIV-infected individuals can stand at risk of reactivation and also in solid organ transplantation. And it can occur late after an event. When I say an event, after a cancer diagnosis or after cessation of therapy. And it's certainly preventable by antiviral prophylaxis. Now, there is a heterogeneity in terms of definitions. I don't think we reached a consensus definition. One definition is of virologic increase by a log of HBV DNA or de novo appearance of HBV DNA when previously it was not detectable. There was a consensus recommendation made a few years back that perhaps it should be defined as a 2-log increase in hepatitis B viral DNA or de novo HBV DNA appearance. And if there is a low level HBV DNA, as I said, it should be about a 2-log increase for it to meet the criteria for reactivation. Now, in the absence of viral DNA measurements, reappearance of E antigen or surface antigen is reasonable evidence. Now, if we were to use a biochemical definition, the suggestion is that it be at least 3-fold increase in ALT if the biochemical tests are abnormal or I'm sorry, if the biochemical tests are normal or abnormal, I should say, or 2-fold or greater increase in baseline levels if initially abnormal. So again, I mixed it up a little bit. 2-fold or greater increase over baseline levels if initially abnormal, 3-fold when they're initially normal. Now, the key serologic marker is antibody to core. And of course, if they have surface antigenemia along with antibody to core, the risk of reactivation is greater. But you have an isolated antibody to core that can represent either an occult infection or it could be cleared infection. And the prevalence of antibody to core alone is variable across the world. In the Western world, it's around 5%, but if you go to countries like Taiwan and China, 50% of the population may have an antibody to core in an isolated manner. Now, this might be the course of HBV reactivation in that you use chemotherapy or immunomodulatory therapy, and then viral DNA goes up, and then it could come down, and then ALT increase follows viral DNA change, and then subsequently towards the end, bilirubin levels go up. Now, the clinical course, of course, can be variable in terms of these 3 laboratory elements. And then in the extreme case, there might be mortality. And in the lesser severe cases, there may be recovery either spontaneously or with hepatitis B therapy. Now, the risk of reactivation is variable. One has to take into account the hepatitis B serologic status and also the intervention or the immunosuppression. And both these play a major role. So if you were to look at corticosteroids, short period of therapy, the risk of reactivation is low, and particularly in the surface antigen negative patients. And then you go to the other end and you have interventions such as a CD20 depleting agent, such as rituximab. And there, the risk of reactivation is high, even in someone who has an isolated antibody core. Of course, the reactivation risk is higher in someone who's surface antigen positive. And then at the bottom, if someone has chronic B, and the risk of reactivation and the phenotype, the presentation of reactivation could be variable based on whether they're inactive carriers or they have immune active chronic hepatitis B. Now, earlier on, reports came out with several drugs leading to hepatitis B reactivation. Amongst them, the one that was responsible for a profound reactivation was rituximab. Then anti-TNFs, there were reports of reactivation, and then the lesser risk agents that have been considered as potentially being responsible for reactivation. So a few years ago, the American Gastroenterologic Association developed a guideline, and I was part of it. And we had extensive discussion about risk stratification based on the intervention, and it came up with some recommendations. So in essence, there are three risk groups. The ones are greatest risk, that is greater than 10% risk for reactivation, are those who receive B-cell depleting agents, anthracycline derivatives, these are chemotherapeutic agents. And the risk is variable on whether, and is based on whether they're surface antigen positive or negative, and then have isolated core. Clearly, the risk is was demonstrated to be quite high with B-cell depleting agents. Then the challenges in the moderate risk category, and the moderate risk is anywhere from 1 to 10%. And some drugs, it could be at the lower end of the 1 to 10%, and some could be closer to the 10% range. And then, of course, the other factor that comes to play a role is the serologic status, whether it's surface antigen positive or isolated core positive. A lot of concerns around TNF alpha inhibitors, cytokine integrin inhibitors, tyrosine kinase inhibitors, etc. And the risk, we could say at that stage, was that it was between 1 to 10% with these various agents, and more so in surface antigen positive individuals related to isolated anti-core. Now, a few years ago, the FDA looked at rituximab-associated reactivation, and there's a meta-analysis done. At that time, there were 27 case reports, and overall case series reports had 156 patients that were looked at. And in essence, post last rituximab dose, the median time to reactivation was around 3 months, but the range was 0 to 12 months, and about 30% reactivated after, or more than 6 months after the last dose of rituximab. And when they looked at anti-HBC positive patients, the odds of reactivation in those who received rituximab relative to those who did not receive rituximab was about 5.73. So pretty high odds ratio for reactivation in isolated anti-core patients receiving rituximab. Now, over the past few years, several cytotoxic agents have come out. And these are the classes. It's beyond the scope of my talk to go over all of these classes, but drugs. But more importantly, I think we need to know a little bit about tyrosine kinase inhibitors. And last but not least, and quite importantly, we need to know as to what the reactivation risk might be in the context of immunotherapy. You have a number of immunotherapeutic agents, immune checkpoint inhibitors that have come out, etc. So if you were to look at evolution of tyrosine kinase inhibitors over the past 2 decades, several of them have been approved for a variety of indications. And so it's been a challenge trying to figure out if there is a risk of reactivation in the context of tyrosine kinase inhibitors, because they can be hepatotoxic themselves. So how do you distinguish hepatotoxicity from, due to these drugs from hepatitis B reactivation? Of course, you do have serologic studies for hepatitis B that can help differentiate these two clinical situations. And then What has compounded the issue is that there are combination strategies that are being used now. Cytotoxic agents in combination, kinase inhibitors in combination, immune checkpoint inhibitors in combination. Then you might have a cytotoxic drug plus an immune checkpoint inhibitor plus a kinase inhibitor. And so it's really become a challenge to review the literature objectively to see as to whether this is hepatitis B reactivation or if the drugs themselves are causing liver injury. And lastly, at least in the field of hepatology, we use immune checkpoint inhibitors in patients with underlying liver disease and HCC. So how do we differentiate underlying liver disease related dysfunction from drug-induced hepatotoxicity? It's a huge challenge. But when I examined the literature and I looked at PD-1 inhibitors, PD-L1 inhibitors, and CTLA-4 inhibitors and the risk of reactivation, there are relatively few cases reported in the literature. Mind you, fair number of these trials excluded patients with hepatitis B infection. So it's a selected population in a fair number of these trials. So the real evidence would be from real world to see as to what the risk of reactivation might be in patients with ongoing hepatitis B infection or past hepatitis B infection. To that end, the group in Hong Kong came out with a nice paper this year where they looked at hepatitis flares during immunotherapy in those with current or past hepatitis B infection. They had 2,494 patients who had received immunotherapy. Then eventually the population that served basis for their evaluation was then 990 patients. There are 397 surface antigen positive patients and 593 surface antigen negative patients. So they looked at biochemical flare, and they defined biochemical flare as more than 2 times upper limit of normal. And in the surface antigen positive patients, 40% had biochemical flare. Remember again, these are patients with underlying liver disease, and whether this biochemical flare is related to liver disease or to the drug is unclear. And the surface antigen negative patients, 30% had biochemical flare. What is more important is that of these 397, incidentally, all these surface antigen positive patients were on hepatitis B therapy. About 16% of surface antigen negative patients were prophylaxed with hepatitis B drugs. And you look at hepatitis B reactivation defined as more than 2 log increase in hepatitis B viral DNA from baseline. It happened in only 2 patients amongst these surface antigen positive patients who were on hepatitis B therapy. And there was one seroconversion in this population of surface antigen positive patients where they lost surface antigen. And then there was one seroreversion in one patient who was surface antigen negative, where the patient turned surface antigen positive. What is most important is that from this data, that surface antigen positive patients, anyway, you have them on hepatitis B therapy, it is not necessary to prophylax these surface antigen negative patients when they have isolated core. There's the risk of reactivation, that is true hepatitis B reactivation, is low. Only one had seroreversion. This biochemical flare could be due to any number of reasons. And if you look at Kaplan-Meier analysis for overall survival in these patients who had hepatitis flare, when I say again hepatitis flare, this is biochemical flare, compared to those who did not have hepatitis flare, there was no difference in survival. Now, AGA guideline suggests that for high-risk reactivation cases, surface antigen positive and even antibody to core alone positive patients, in the context of B-cell depleting agents, should have antiviral prophylaxis for at least 12 months after discontinuation of immunosuppressive therapy. Ideally, in surface antigen positive patients, it's best to continue with therapy because there may be a later risk of reactivation in those cases. But in isolated core, you could stop prophylaxis after 12 months after discontinuation of immunosuppressive therapy. But the challenge is in these moderate risk patients, 1 to 10% risk, and you look at variety of these drugs. One could use antiviral prophylaxis for at least 6 months until for 6 months after discontinuation of these agents. But then one could also elect to follow these patients and not institute hepatitis B prophylaxis. The trend is not to institute hepatitis B prophylaxis, someone with isolated anti-core in the context of drugs such as TNF-alpha inhibitors. And this is data to support this. There's a huge study from Kaiser Permanente database, over 8,800 adult patients who are on TNF antagonists. And there were 178 isolated anti-core patients. And then none had hepatitis B reactivation. And these patients were not on any prophylaxis. The reactivation was in surface antigen positive individuals. Choosing an antiviral regimen for hepatitis B prophylaxis, all the earlier studies had been done with lamivudine and tenofovir, et cetera. The drugs with high genetic barrier resistance would make intuitive sense. Tenofovir and tenofovir and tenofovir alafenamide would be preferred. So this is my overall recommendation for candidates with active or occult hepatitis B infection with regard to follow-up of prophylaxis. I'll focus on this anti-core alone positive. They may have anti-HBs. And if they are going to go on to a drug that has a higher risk of reactivation, such as rituximab or other B-cell depleting agent, obviously you want to prophylax them. The moderate risk and low risk, you can elect to follow them periodically with biochemical tests, surface antigen, and viral DNA. But it's not practical in certain parts of the world to do surface antigen and DNA. In Asia and Europe, in certain countries such as Taiwan, they do surface antigen and follow-up. In Europe, they do surface antigen follow-up. But it's where it is not readily available, one could elect to use ALT to follow these patients who have isolated anti-core. So to summarize, there are a number of new classes of drugs and new drugs in various classes of immunomodulators that are being approved rapidly. Combination therapies are being used. It's really challenging to assess the rate of reactivation and particularly differentiate from drug-induced hepatotoxicity. The risk is variable and depends on hepatitis B serologic status and the type of immunosuppressive or the immunomodulator drug that's being used. All patients who go on to an immunomodulatory drug or immunosuppressive drug should be screened for hepatitis B markers. You need to assess the risk for reactivation and institute prophylaxis in appropriate cases. And there are guidelines in place, but the challenge is that they need to be updated because new drugs are just coming out of the woodwork like they're going out of style. And if prophylaxis is not instituted, follow-up every 1 to 3 months for the moderate risk category and every 3 to 6 months for the low risk category with the liver profile and as needed surface antigen and DNA would seem appropriate. Well, I thank you very much for your attention and I'll stop here.
Thank you, Dr. Reddy, for excellent presentation. Now I'll invite my co-chairperson, Dr. Jayanti, to take over and introduce the next speaker.
Thank you, Dr. Sarai. we now move on to one other important session, one other important topic in this session, and that is etiology-based therapies to prevent liver transplant in advanced cirrhosis. And to speak to us on this, we have Professor Shalima from All India Institute of Medical Sciences. While he takes on the topic, I request the speakers to answer some of the questions in the chat box, as we may be running short of time after this talk. Over to Dr. Shalima.
Thank you for the kind introduction, ma'am. With increasing grades of fibrosis, there's associated increase in portal hypertension as represented by an increase in hepatic venous pressure gradient. This eventually manifests as clinical events. As the fibrosis grades progress, there is also an increase in bacterial translocation and inflammation. Eventually, the clinical presentations include a stage of compensated cirrhosis, progressing on to decompensated cirrhosis, and a severe form of presentation, which is acute on chronic liver failure, which you have heard recently in the last talk. In addition, patients with cirrhosis do also develop hepatocellular carcinoma. So, these are the indications of transplantations that may include a state of decompensated cirrhosis, acute and chronic liver failure, and development of hepatocellular carcinoma in these patients. So, what are we targeting with cure in terms of management of etiology? Can we reverse the whole pathogenesis in terms of fibrosis and the associated complications which have developed? So let's see what is the effect of these therapies in reducing progression or causing a reversal. We've got multiple drugs that includes nucleoside and nucleotide analogs approved for hepatitis B. In addition, interferon is also available for management of hepatitis B virus infection. Data with the drug tenofovir shows that at 5 years of use of this drug, there is a regression in fibrosis in almost 50% of patients. In addition, those patients who have an underlying cirrhosis, almost 3/4 of them will no longer have cirrhosis at the end of 5 years. Similar data is available on the drug entecavir. This study, which was a long-term follow-up paired biopsy, showed that 1-point improvement in the Ishaq fibrosis score was seen in almost 88% of patients, suggesting that these drugs cause regression of cirrhosis when treated over a long period of time. In addition, interferon has been used in select group of patients, that is, patients with advanced fibrosis and cirrhosis. Important to note is that HBs antigen loss is associated with improved survival and low risk of hepatocellular carcinoma. And we know that interferon is associated with a higher risk of HBs antigen loss as compared with oral nucleotide and nucleoside analogs. Important to note is the higher risk of side effects which occur in patients with cirrhosis when interferon is used. This interesting meta-analysis evaluated the role of antivirals in reducing death, hepatocellular carcinoma, and decompensation. All these three complications were much less as compared to those who were not treated. So there is definitely a benefit of use of antivirals in reducing the progression and the development of complications in hepatitis B virus related cirrhosis. So the million-dollar question next is, which drug to choose for prevention of HCC? Do we choose entecavir or tenofovir? Multiple meta-analyses of late are available over the past 2 years. I'm showing you the data from this recent meta-analysis published this year. The authors specifically looked at a group of patients with cirrhosis, and what they found was there was no difference when they adjusted for all other factors between the HCC prevention rates of both tenofovir and entecavir. So the current jury is you can choose either of them. What happens to those patients who've already had a decompensation and are on the liver transplant list? Use of antiviral in these patients as compared to those who do not receive antivirals, there is an increase in the liver transplant-free survival in patients who are treated with antivirals. The data also suggests is that there is an improvement in the child score and the improvement in MELD score over time. Important to note is that 1/3 of your patients who are on antiviral therapy do get delisted from the transplant list. An interesting study from the Professor Sarin's group from ILBS reported a benefit of tenofovir in improving the survival of patients with acute and chronic liver failure. This interesting meta-analysis looked at the effect of antiviral therapy after curative therapy in patients with HCC. So what they did is they collated all studies in which patients had undergone curative therapies in terms of RFA and TACE and looked at the comparison between the patients who had received antivirals versus those who had not received antiviral therapy. The data suggests that use of antiviral therapy was associated with a reduced risk of HCC recurrence. In addition, it also translated to an improvement in overall mortality, and mortality due to liver failure was less among those patients treated with antiviral therapy. So, important to state out here is that we need to prevent HPV infection, and universal immunization is the way forward to it. So once you cure HPV or prevent HPV, you'll not have any of these complications which we have discussed. For hepatitis C virus infection, interferons were the initial drug of choice. Now, the direct acting agents are available, which are associated with high cure rates ranging from almost above 95% of SVR12. When we look at the data of DAA on liver stiffness measurements, the data suggests that there is a reduction in the liver stiffness measurements over time, and this reduction in LSM does maintain and the LSM keeps on reducing even after the completion of therapy. This study, published just 4 days back in Journal of Viral Hepatitis, took 50 cirrhotic patients and measured their serial liver stiffness measurements. What they showed, interestingly, is that there is a reduction in the LSM measurements over time. But if you look closely at this data, most of these LSMs, the mean value still remains above and is within the cirrhotic range, indirectly suggesting possible benefit of DAA on the liver fibrosis. This study looked at the serial hepatic venous pressure gradients in patients with hepatitis C virus treated with DAAs. What they showed is that therapy with DAAs is associated with a reduction in hepatic venous pressure gradient. And we know that complications, HVPG correlates with complications in patients with chronic liver disease. Important to state out here is that when subgroup analysis was done in different groups of hepatic venous pressure gradients, that is above 10, above 12, above 16, DAA was shown to be effective in reducing HVPG across all 3 groups. The data on PEG interferon in patients with child A cirrhosis shows very clearly that those patients who have achieved an SVR as compared to those who have not achieved an SVR have a lower incidence of HCC. These patients who achieve SVR also have a reduced hepatic decompensation. And importantly, what we have heard in the previous talk is the risk of bacterial infections being an important cause for as a precipitant of acute or chronic liver failure. As per the Inasl definition, there is also a reduction in bacterial infections in patients with child A cirrhosis who achieve an SVR with PEG interferon. Going further, the study also showed us that the overall survival in patients who achieve an SVR is much better as compared to those who do not achieve an SVR, and the liver-related event-free survival is also better as compared to those who did not achieve an SVR. The DAAs, which have come off late, so we do not have long-term data, but this study showed possibly the risk of clinical disease progression may be less among those patients who achieve an SVR as compared to those who do not achieve an SVR. This study showed that in patients with decompensated cirrhosis, which was defined as development of ascites, variceal hemorrhage, encephalopathy, or jaundice, interestingly didn't show any difference between those patients who've been treated with DA versus not treated with DA. So probably at an advanced stage, we still need more data regarding what were the exact benefits of DA in such a group of patients. An interesting study from Professor Raj Reddy's group, the real life experience, which included patients with advanced and decompensated cirrhosis, the HCV target group. The authors over here divided the patients into two cohorts with a baseline MELD of 10 to 15 and MELD above 16. What they showed out here is that there was a marginal benefit only in the MELD score and other parameters between the group who achieved SVR versus the group which didn't achieve SVR, suggesting again the fact that in decompensated cirrhosis and advanced cirrhosis, possible the benefit of these drugs still need more data. So what happens to those patients who are on the transplant list? HCV cirrhosis on transplant list, when treated with DAA, almost 1/4 of them will get delisted. Important to state out here is that none of those patients with a MELD above 20 in this study got delisted. So a definitive benefit of DAA on delisting from the transplant list. What happens to the incidence of hepatocellular carcinoma when treated with DAA? Interesting studies over here show that when treated with DAA, there is a reduced incidence of hepatocellular carcinoma, and this goes to as high as 71% reduction in the hepatocellular carcinoma risk among those who achieve an SVR compared to those who do not achieve an SVR. What about those who already have an HCC? Does the use of DAA reduce the risk of recurrence? Small sample size study. The data from this study shows us that possibly no benefit in such a situation, but we need more data regarding the recurrence of HCC after treatment with DAA. So to summarize for hepatitis C, SVR is associated with a reduction in the progression to cirrhosis in patients with chronic hepatitis. Those with compensated cirrhosis, there is a fibrosis regression, there is an improved outcome, and the risk of HCC occurrence. On the decompensated and HCC front, there is a reduction in the further decompensation with treatment with DA, and there is an improved survival. But the risk of recurrence of HCC, we still need more data. Coming to autoimmune hepatitis, among which the drugs available include corticosteroids, azathioprine, drugs like mycophenolate mofetil, and tacrolimus, and the drug which you heard in the last talk is rituximab, which was associated with a very high risk of HPV reactivation. We know from data now is that autoimmune hepatitis patients with a higher HAI score and those with cirrhosis have a higher all-cause death and requirement of liver transplantation. A paired biopsy study showed us that among those patients treated with corticosteroids and azathioprine, on follow-up, almost 60% of them have a reduction in the fibrosis, and a similar proportion of patients have a resolution of cirrhosis. Similar data published from the Mayo Clinic also shows us that use of corticosteroids is associated with a reduction of fibrosis and the histological activity index. We also know that those patients with autoimmune hepatitis who have a remission have a reduced requirement of liver transplantation and have an overall improved survival. What about decompensated cirrhosis? So even in that subgroup of patients, in select patients, treatment with immunosuppression has been associated with an improved outcome as compared to those not treated. Data from the ILBS group shows that a select group of patients with ACLF can also be treated with immunosuppression in forms of corticosteroid, and you can avoid a transplant in select patients. In conclusion, chairpersons, ladies and gentlemen, therapies for hepatitis B virus, hepatitis C virus, autoimmune hepatitis in patients with advanced chronic liver disease improve fibrosis, decompensation, survival, and also the risk of hepatocellular carcinoma. It is important to diagnose these patients early to prevent advanced chronic liver disease and complications from occurring. Thank you for your patient hearing.
Thank you, Professor Shalimar, for that wonderful coverage of a fairly large topic covered in about 15 minutes. And I'm extremely thankful on behalf of my co-chairs for our international speakers who could answer most of the questions on the chat box. So I think, Dr. Shalimar, I have just one question for you because most of the questions have been answered by Professor Reddy and Professor Raji. Do you think most of these drugs have anti-fibrotic action? Because F4 moving to F3 or F3 moving to F2, is it an anti-fibrogenic action that makes them move from one to the other? Because we always say that fibrosis is the end stage towards cirrhosis.
I think it's a complex of, so when we look at the pathogenesis of across the viral infections and the autoimmune disease, it is more of the disease activity, inflammation going on. So one mechanism is like reducing the inflammation, which prevents the progression. So that's probably is the reduction. And apart from that, probably these drugs have not been shown or reported to be primarily anti-fibrotics, but it is by reducing the inflammation. Yeah, so that's the way it prevents, and with time, possibly a reduction in fibrosis
Very
with
much,
modification.
Professor. Thank you so much. On behalf of my co-chairs, Professor Chawla and Professor Anand Sarai, we thank our international speakers for this wonderful session, and over to the organizers. Thank you.
Thank you so much. That was a wonderful session with some very enlightening talks. And thanks to the chairperson as well as speakers. Now we move to the second part of the PG course. To invite the speakers, may I request Dr. Kar to begin the session. Is Dr. Kar there?
Sir, he's just logging in.
So the chairpersons for this session are Dr. P. Kar, Dr. Manisha Dwivedi, and Dr. MP Sharma. So if I think Dr. Kar and Manisha Dwivedi are not there, I would request Dr. MP Sharma to start the proceedings. Sir, you are muted. You'll have to unmute yourself.
So Dr. Manisha is there.
Hello.
Yes, sir. Please go on, sir.
Yes, the first speaker of this session is Dr. Pankaj Puri, who is going to talk about the management of diabetes in cirrhosis. Dr. Pankaj Puri, please. Is he around?
Thank you, sir. I'm here, sir. I'm just sharing my screen. And
Yes.
I hope you can all see my screen now.
Now I can introduce you. He is the Director of Gastroenterology and Hepatology at the Fortis Escorts Liver Digestive Disease. And Dr. Pankaj Puri has a very remarkable career in the Indian Army, after which he has joined these Fortis Hospital. Dr. Pankaj Puri, please, on management of diabetes and cirrhosis.
Thank you, sir. Thank you for your kind introduction. I'll be speaking on diabetes and cirrhosis, and this has always challenged me because I always found it very difficult, because many of these patients would come with complications related to diabetes and diabetes related drugs. 30 to 40% of patients with cirrhosis have diabetes, and diabetes has an impact on all the various stages of liver diseases. If you have normal patients, you have a higher incidence of NAFLD. People who have chronic liver disease have advanced progression of fibrosis. People with cirrhosis would develop higher risk of HCC and a decreased overall survival. Even after liver transplantation, there are higher complications, higher post-transplant mortality, and new onset NAFLD after transplantation. There are many challenges in the management of diabetic patients with cirrhosis. Firstly, there's a difficulty in diagnosis and monitoring these patients. There are challenges in the treatment itself, and post-transplant as well, there is a higher incidence of diabetes, which may be worsened by the immunosuppressive drugs. Let's look at the challenges in diagnosis and monitoring. First of all, these people have lower fasting blood sugars, and because of impaired gluconeogenesis and decreased glycogen storage. So if you only do the fasting blood sugar, you may miss these patients. Glycosylated hemoglobin, HbA1c, which is commonly used for monitoring, may be falsely low, especially in people who have hemolysis or anemia. And this may be there because the RBC's lifespan is shortened because of hemolysis as a part of hypersplenism, or blood loss as a part of GI hemorrhage. So as an alternative, we can check for other glycated proteins like albumin and fructosamine. These would probably reflect the glycemic status more accurately. But the problem is that they have a shorter half-life, unlike HbA1c, and they need to be verified for their validity further. Frequent monitoring of self-glucose is important. When we look at treatment, the specific challenges are many. First of all, many of these patients have cognitive impairment because of overt HE or MHE. They may forget to take the drugs, they may calculate the doses wrongly, miss meals, they have a high incidence of hypoglycemia, which may also be worsened because of reduced insulin clearance. And hence the glycemic targets and the therapeutic regimen should be tailored to avoid hypoglycemic events. There is also alteration in hepatic flow and portosystemic shunting, which results in very high serum concentration of some of the drugs. The drug metabolism itself is affected. There is decreased hepatic metabolism, decreased cytochrome P450, changes in intestinal permeability and microbiota changes, which all affect drug metabolism. Protein-bound drugs are affected by the presence of hypoalbuminemia, and drugs which are excreted from the liver are affected if there is cholestasis. Diet intake is always a challenge in people who have either sarcopenia or obesity. People who are obese, they may be worsening of sarcopenia if you try and correct the obesity. And if you're trying to correct sarcopenia and increase dietary restrictions, requirements, this may affect the glycemic control. Renal dysfunction is not uncommon, and there may be accumulation of drugs in the metabolites and a higher incidence of lactic acidosis. The drugs used themselves may have hepatotoxicity, and hence these drugs need to be used very carefully. The first level of management always is nutrition and lifestyle measures, which is routine, and dietary requirements to combat sarcopenia are a calorie intake of 35 to 40 kilocalories and a proteins of 1.2 grams per kg. And in the presence of malnutrition, this would be about 1.5 grams per kg. So a combination of diet and exercise is the first regimen, but I will focus more on pharmacotherapy. Besides insulin, the various groups of drugs which are used are insulin sensitizers, which is metformin and pioglitazone. The secretagogues, which is repaglinide and sulfonylureas, the incretin-based therapies, which are DPP-4 inhibitors and the GLP-1 receptor agonists, and drugs which either interfere in glucose absorption or reabsorption, absorption from the gut by alpha-glucosidase inhibitors, and reabsorption from the tubules by the SGLT2 inhibitors. You know, this, I'm only showing this guideline not to try and read it out, but to show you that the American Diabetic Association guidelines have focused on many things. They focus on cardiovascular disease, they focus on heart failure, kidney disease, and many other things. But there is no focus on the liver and the liver-related illness in any of them. So it's very important to look as to what our patients would need. The basic principles of choosing anti-diabetic drugs in cirrhosis is, firstly, we have to consider the comorbidities, which are including cardiovascular, renal, and obesity. What is the compensation of the liver? What's the risk of hypoglycemia? And obviously, cost plays a role. In compensated cirrhosis, which is NASH related, we would prefer drugs which may have efficacy against NASH. In decompensated cirrhosis, we would choose drugs with the least risk of hypoglycemia and least hepatotoxicity. If the patient has renal dysfunction, there is a risk of lactic acidosis, and that needs to be kept in mind as well. Early introduction of insulin should be there if there is evidence of ongoing catabolism, weight loss, if there are symptoms of hyperglycemia or the HbA1c levels are more than 10 or the blood sugar levels are more than 300. So if you look at the drugs which have been tried in NASH, I won't dwell too much on this, but pioglitazone, GLP-1 receptor agonists, SGLT2 inhibitors, DPP-4, they've all been tried to some extent or the other. And recently there's been a paper which has come out in NEJM on the GLP-1 receptor agonist, semaglutide, with high resolution of NASH. So some of these drugs can be considered in compensated cirrhosis. But if the patient has advanced cirrhosis, we have to look at many other issues which are important. If we look at the insulin sensitizers, metformin has a risk of lactic acidosis, and this is often a concern by many people, and I'll dwell on this a little further. Pioglitazone itself has hepatotoxicity, increased edema, increased ascites, and osteoporosis, and should not be used. Among the secretagogues, which is the repaglinide and the sulfonylureas, both of them are avoided preferably because of hypoglycemia in the first, and the repaglinide may have obesity, hypoglycemia, and hepatitis as well. The incretin-based therapies, which are DPP-4 inhibitors and the GLP-1, have both been used, preferably DPP-4. They don't have hypoglycemia, among these drugs, linagliptin is probably safer because it's renal excretion. The GLP-1 agonists have been tried in the lean study for NASH. They don't have hypoglycemia, but there's not enough not enough data to recommend their use regularly. Drugs which interfere with glucose absorption and reabsorption have both been tried and have been reasonable, and I will dwell on these a little further. Among these groups, I'm going to choose the favorite 4 and talk about 4 of these groups. Metformin is always the preferred initial drug therapy for diabetes and should be the same in people with cirrhosis. There is an exaggerated concern for metformin-associated lactic acidosis, but it's very rare, especially if the renal functions are normal. There are many advantages of metformin. There's a reduction in hepatocellular carcinoma risk. There's reduced incidence of overt encephalopathy. And there has been study which shows that it is associated with increased overall median survival in people who continued the drug after diagnosis of cirrhosis and diabetes. Now, this was a study which was done which showed that metformin inhibited glutaminase activity and prevented against hepatic encephalopathy. It took 82 patients and gave them metformin, and the controls did not receive metformin. Besides this, it also checked in vitro glutaminase activity. And they looked at the hepatic encephalopathy and found that metformin decreased glutaminase activity as well as protected against hepatic encephalopathy. There was much lower encephalopathy in people who were receiving metformin than those who were not receiving metformin. There's another study which showed that if you diagnose cirrhosis in a patient with cirrhosis, in a patient with diabetes and you continued metformin, they would have a prolonged survival. And continuation of metformin after cirrhosis reduced the risk of death by about 57%. The second group of drugs is the SGLT2 inhibitors. Now, there was this study which had reported 3 cases of NASH-related cirrhosis with diabetes, which were treated with SGLT2 inhibitors, and there was amelioration of ascites. The SGLT2 inhibitors increase natriuresis by inhibiting the proximal tubular reabsorption of both glucose and sodium. And this offers a new therapeutic approach for the treatment of ascites and cirrhosis. But we have to be cautious in people who are already on diuretics because it may have volume depletion. Also, UTI may be a concern. The third group of drugs is acarbose. Now, acarbose has little side effects other than some increase in diarrhea and flatulence. It inhibits glucose absorption from the gut. It changes the gut flora, and there's a decrease in proteolytic flora, which increase the ammonia levels. The laxative effect may also contribute to the beneficial effect in hepatic encephalopathy. In this study, there were 117 patients, and they found that the acarbose decreased the ammonia levels and improved hepatic encephalopathy, and maybe okay in people who have low-grade encephalopathy. The fourth group of drugs is the DPP-4 inhibitors. Now, this is the metabolism of these drugs and their excretion of these drugs. And if you look, linagliptin is one which is excreted unchanged in the feces, while all the others are excreted in the urine. So that is an important factor where you must consider linagliptin, especially if there's renal dysfunction. Saxagliptin is activated in the liver to the major metabolite. And so that may be of concern because it may not get activated enough. So among these group of drugs, saxagliptin, which has an active metabolite in the liver, should be avoided. There are drug-induced hepatitis reported vildagliptin, and linagliptin is probably the safest in renal dysfunction. So other drugs to be avoided would be the pioglitazones, the sulfonylureas, the repaglinide. The GLP-1 receptor agonists don't have enough therapeutic experience, so although they have been reasonably safe. If you look at the insulins, choosing the insulins, the analogs have faster onset of action and shorter duration compared to the regular insulins. And among these longer acting insulins, glargine, detamir, and degludec have lower hypoglycemia and probably would be the better ones. This sort of summarizes most of the data which I've shown so far. Metformin has been shown to have risk. There is a fear of lactic acidosis. And the recommendations of their use depending on child A, B, and C. The green ones are where it can be safely used. The red ones where they should be avoided, and yellow is with caution. So pioglitazone we should avoid or not use at all, and similarly so for the sulfonylureas here. The DPP-4 inhibitors, vildagliptin, should be avoided, and probably the safest of the lot would be linagliptin, especially because it has a primary renal excretion, and it may be better in people who develop HRS. The SGLT2 inhibitors have been used with some efficacy in child A and B and may have role in ascites control in people who have child C as well. The repaglinide should be avoided. The alpha glucosidase inhibitors, which is acarbose, is of fair use and has been shown to have benefit in people who have early hepatic encephalopathy. The insulins obviously would be the safest and can be titrated, but the short-acting insulins are better. So if you have a person who has cirrhosis, then you must check and monitor them carefully, and the fasting glucose may be low, HbA1c may be unreliable. The first step would be lifestyle interventions with diet and exercise. The step 2 would be pharmacotherapy. Among pharmacotherapy, it's very common to have people on sulfonylurea and repaglinide, and these should be stopped. In both compensated and decompensated cirrhosis, you should consider using metformin. If the patient has decompensated cirrhosis, you must be careful with metformin and renal dysfunction. The alpha glucosidase inhibitors SGLT2 inhibitors and linagliptin or the DPP4s can also all be considered. But if the patient is very badly decompensated, insulin may be a better choice. In people who have compensated cirrhosis, comorbidities need to be kept in mind. With hypoglycemia, we can use any of the 4 drugs, which is metformin, SGLT2, GLP-1, or DPP-4. If there is obesity, weight neutral drugs should be considered. Renal dysfunction, linagliptin is probably safer, as I mentioned. In encephalopathy, the important thing is to have lower glycemic targets, and any drug which is used, which can cause hypoglycemia, should be avoided. So managing patients with cirrhosis and diabetes and its related complications requires a multidisciplinary approach, which not only includes the hepatologist, the endocrinologist, diet, and cardiology, but very often as hepatologists, we would land up adjusting all these drugs in our outpatient clinic. And so it's important for all of us to look at what he's taking and not just write continued treatment. Thank you. I think I will stop at that.
Dr. Manisha?
I hope I was on time and I made up for lost time.
Thank you, Dr. Puri. That was an excellent talk and on a very important clinical topic, which would be useful for most of us. Now we move on to the next topic, and that is the management of acute kidney injury in liver disease patients, a stepwise management approach. The speaker would be Rakhi Maiwal, and who's currently working as an additional professor of hepatology and head of liver intensive care unit at the Institute of Liver and Biliary Sciences, New Delhi. She has special interests in renal dysfunction in patients with cirrhosis and liver failure and critical care hepatology. She's also the Vice Secretary of the International Club of Ascites and has a host of international publications to her credit. Dr. Rakhi, please.
Thank you, ma'am, for this very nice introduction. And I would like to thank Inasl and Dr. Kaushal for giving me an opportunity to take up this topic. So what I thought was I'll take a case scenario and I'll approach to the case stepwise with the help of this case. So this was a 39 years old gentleman who was a resident of Delhi, a known case of portal hypertension, chronic liver disease. He had history of prior decompensations, diuretic responsive ascites, hepatic encephalopathy, and diabetes. And what he presented to us was a worsening of ascites of 20 days duration, decreased urine output of 7 days, and altered sensorium for 2 days. He had a history of large volume paracentesis done 6 days back prior to his presentation. He was received in the emergency. He was presented to us in grade 3 to 4 encephalopathy with low mean arterial pressure, tachycardic. His pH was uncompensated, and in view of the altered sensorium and severe metabolic acidosis with a bicarbonate of 9.8, he was intubated and he was also catheterized, and urine output was just 5 to 10 ml per hour. He had leukocytosis, and the possible source of infection looked as pneumonia. Even though the severity was mild by basal consolidation, there was no SBP, and we can see here there was presence of granular cast on the urine microscopy and tubule epithelial cells. And this patient also has a urine spot sodium, which was high, and a PCR high, and albuminuria with some amorphous urate crystals. His echo was normal, and he had a hyperdynamic circulatory state with the flow track parameters showing vasodilatory and hyperdynamic circulation with high cardiac output. He was planned for a CRRT and he underwent a line placement, catheter placement. He was given fluid administration prior to that, and the response was assessed. So the working diagnosis in our unit in the ICU, we thought this patient was a case of early septic shock with possibly a paracentesis associated circulatory dysfunction. He presented to us with a critical stage 3. The possible cause being acute tubular necrosis secondary to possible ischemic ATN and septic ATN. He had all the complications of this ATN, and the sepsis seemed to be due to pneumonia, which was of nosocomial origin, and he had a multifactorial encephalopathy, and he had a high MEL score of 22 and SOFA score of 8. no comorbidities, and what we'll be discussing is the management of severe AKI stage 3, meeting the criteria for dialysis. So very important is when you make a diagnosis of acute kidney injury, we need to record the baseline serum creatinine, which is the most stable and the lowest value of serum creatinine in the last 3 months. And from here, if there is an elevation of more than 50% in the 7 days time frame, or if there is an absolute increase in serum creatinine of more than 0.3 within 48 hours, this qualifies AKI. And very recently, urine output has been integrated in the diagnosis because you can diagnose AKI with the help of urine output criteria in patients who are hospitalized. The next step is to go to the assessment of background renal disease. So you should see whether your patient has AKI on a background normal kidney or a background diseased kidney. So for that, you need to have an estimate of the GFR in the last 3 months. And if the estimated GFR is below 60 for more than 3 months, this patient has a possibly chronic kidney disease. However, if the GFR is less than 60 for less than 3 months, it is a AKD. In the natural history studies, it has been shown that almost 1/3 of the patients develop acute kidney disease, another 1/3 can develop chronic kidney disease, and almost 80% of these patients with AKD are due to HRS non-AKI. Now, the risk factors of chronic kidney disease should also be evaluated in all these patients. We should look for diabetes, hypertension, obesity, should try to look out a urine microscopy to understand or the imaging evidence of chronic kidney disease. And very recently, we've also shown that you need to record whether the patient has already developed past episode of AKI and number of AKI episodes, because these patients are predisposed and they have poor renal reserve, which can be assessed with the help of renal biomarkers. If you're doing at your center, cystatin C elevation above 2 is indicative of poor renal status. The next step is to assess the status of liver disease, because AKI can occur in different contexts. AKI can occur in patients with acute and chronic liver failure. And we know that in these patients, the AKI spectrum, the cause, the response to different treatment modalities is absolutely different. And therefore, I will not be discussing this because this should be a separate lecture in itself. What I'll be focusing here is AKI in context of decompensated patients with cirrhosis. Here again, you need to understand whether you're seeing this patient as an outpatient, because here the common causes of AKI or acute kidney disease will be more often seen. We'll have more often diuretic related AKI here. These patients may not require admission, and most of them will have a resolution of AKI. You can also see HRS non-AKI in the outpatient setting. As inpatients, we see more often more severe forms, the HRS AKI, ATN, and in the critically ill population, we mostly see these AKI in the background of severe sepsis or systemic inflammation. And there are specific syndromes of septic shock, variceal bleed, and severe paracentesis-induced circulatory dysfunction that are frequently encountered. The step 4 is to identify the spectrum. So you have to find out whether your patient has a functional AKI, which can be either volume responsive or volume non-responsive, or structural AKI, which here would be majority of these patients will have acute tubular necrosis. And how do we do that? We need to take a very good history and clinical examination. Specifically, when you're thinking the ATN is due to nephrotoxic medications, we also need to take a very good history of the drugs like ACE inhibitors, angiotensin receptor blockers, beta blockers, which should be discontinued during the AKI episode, apart from diuretics. A urine microscopy is a very easily available test, and it can tell us very clearly whether the patient has active sediment, as we saw in our patient, urine albumin, protein to creatinine ratio, and a fractional excretion of urea, as has been shown in the context of diuretic use and sepsis, could be very helpful. And in centers, you can also go forward and use the biomarkers. Now, this is just a representative sample just to show you how urine microscopy can just delineate HRS AKI where the sediment is absolutely bland as compared to patients with ATN who have muddy brown granular cast, and these patients also have usually a high urinary spot sodium, but this may not be very reliable in the context of patients who have sepsis. What about biomarkers? This is a recent systematic review and meta-analysis of almost 1,129 patients where 8 prospective studies were included. And the authors showed that urine interleukin 18 and lipocalin-2 or the NGAL had an excellent accuracy to detect ATN and also predicted mortality in these patients. Step 5 and step 6 is to stage the severity and assess the cause. We are using the KDIGO definition that has been recently proposed. So wherein we can use the urine output criteria for AKI diagnosis, and subsequently with the help of creatinine elevations, the degree or the duration of decrease in the urine output can tell us about the severity of the AKI. Now, why is this important? And this is a prospective cohort study that we performed in our center, which included 291 patients, wherein 58% of these patients had AKI presentation, and 52% of these patients went on to either a progressive or a persistent AKI at day 7. So they did not have a response to the therapeutic interventions. 5% of these patients had died, as against 24% who had a resolution. And the maximum stage 3 of AKI based on the KDIGO staging was associated with worse outcomes. And what were the factors which were predicting such a severe course? It was the presence of severe systemic inflammation. We see very often multi-drug resistant bacteria, elevated serum bilirubin, and the degree and severity of extrarenal hepatic organ failures. That is, the presence of shock, hepatic encephalopathy, or need of mechanical ventilation was associated with the progression of AKI. So what do we do to facilitate recovery? And this is the algorithm. And I would say that it is totally deficient, because when you stratify your patients based on the stage 2 or 3, when you're dealing with severe AKI, like we see in our patient, it is not necessary that everybody gets 20% albumin at 1 gram per kg. And obviously the applicability in patients with ACLF and critically ill cirrhotics cannot be done, because you cannot be waiting for 48 hours. You're looking at the urine output. You have to act if the patient is having progression. What should be the ideal choice of vasoconstrictor? What should be the target map? And how do you manage ATN in these patients is absolutely deficient in this algorithm. So when we have stratified the cause of AKI, if it's a pre-renal AKI, we have to do a very appropriate volume expansion. And what do we have in our kitty? We can give 5% albumin, we can give 20% albumin, we can use crystalloids, which are balanced crystalloids like a plasmolite, normal saline. We can use a combination of colloids or crystalloids. And you should be using now the dynamic indices for fluid responsiveness, because each patient will respond differently to a fluid therapy. So fluid responsiveness is more important, and we should be setting our targets for a mean arterial pressure, urine output, and microcirculatory parameters like the arterial lactate. Now, in context of patients who have sepsis-induced hypertension, so we talked about microcirculation, we talked about kidneys, but the two other very important organs in this context is the lungs and your heart. So these are precious organs in the ICU or in the sick population, because I'll show you some data here. And this is the data of 5% human albumin, where we compared it in a randomized controlled trial in context of sepsis-induced hypertension, where we showed the superiority of this fluid as against normal saline in patients with, and this albumin was absolutely safe. There was no problems with the lung, and there were no complications that were seen. This is another randomized controlled trial that we performed comparing 20% albumin for fluid resuscitation in patients with sepsis-induced hypertension, and we compared it against the plasmolite. However, the results here clearly showed that 20% albumin caused significant worsening of the CVP, the IVC, and the PF ratios, and it was not very well tolerated when given rapidly for resuscitation in this set of patients. Even though the volume of fluid infused was just 453, as against liters of fluid which were given in plasmolite group, still plasmolite was much more safer. Similar results have been published by the entire group of investigators, where they showed that 20% albumin when given to hospitalized patients with cirrhosis caused pulmonary complications when given in almost 1 in 4 patients. Therefore, we have to be very, very careful in context of sepsis-induced hypertension in rapidly infusing 20% albumin. What about when we have made a diagnosis of HRS-AKI? We know that we have removed the criteria for serum creatinine. We can use the urine output. If your patient has not responded, has a bland urine microscopy, and is not having shock, he's more likely to have HRS. And from multiple studies done in decompensated patients with cirrhosis, it has been shown that terlipressin is as good as norepinephrine. However, this is the recent study by the Raj Reddy and their group and the Canadian group of investigators, where again it was shown that terlipressin and therefore should be very cautiously used in context of sicker patients with kidney injury. Now, what about management of ATN? If you have diagnosed your patients with ATN, it is again very important to identify the cause and the phase of ATN. And how do we do that? Because if the patient is in the early phase of ATN, he will normally recover once you remove the precipitating insult. And in the later injury phase, however, it becomes very difficult. And herein where you can use your indices of severe metabolic acidosis, hypokalemia, oliguria, the time for which there is anuria, hypophosphatemia, which was all there in our patients, even though it was the early stage. And we have to do and identify this ATN early on, because a timely dialysis should be considered in patients with liver disease. Otherwise, these patients go on to develop intradialytic hypertension and other complications. Now, can we use the biomarkers? And this is a data of urine NGAL and cystatin C. And we showed that a combination of urine NGAL of NGAL level of above 1400 or a cystatin C above 3 was able to tell us correctly that a patient with liver disease in the ICU would require dialysis. Now, in the ICU, when we're managing, we're giving fluids to a patient, we may not be having the facility of doing a transpulmonary thermodilution. However, if we do have an extravascular lung water assessment, is very, very helpful in identifying hypervolemia and difficult patients where we need to give fluids and take difficult decisions. And intra-abdominal pressure monitoring can also be very, very helpful, because here, if your intra-abdominal pressures are high, this indicates hypovolemia, a capillary leak syndrome, and a therapeutic or modest volume paracentesis can also enable improvement in the renal perfusion. So I go back to our case here. So what we did in this patient was to give him 5% albumin and plasmolide, was given broad spectrum antibiotics. He was given, and we can see here that there was an improvement in the heart rate, and there was an improvement in the urine output, which was gradual. And by day 4, the urine output had improved to 50 ml. Day 2, the cultures of the lung had multi-drug resistant Klebsiella, which a polymyxin B was added. His shock resolved by 24 hours. His ATN recovered by 96 hours, and he was extubated by day 4. All the other pH and the other parameters we can see here by day 2, there was a decline in the uric creatinine, the sodium, the potassium, phosphate levels all showed a gradual improvement in these patients. So we were able to save dialysis. The X-ray showed improvement in pneumonia. And even though the SVR was low in this patient, we did not use terlipressin, and norepinephrine was the drug that we used, because this patient had ischemic ATN, and terlipressin would have worsened the renal ischemia. Renal biomarkers also were consistent that this patient should not have been subjected to a dialytic therapy. Urine microscopy also showed improvement and resolution of the CAS. And the urine protein creatinine ratio, we can see here how it declines, and urine spot sodium also became normal while this patient had resolution of AKI. So this is my summary slide where I would like to show how do we need to manage these patients with AKI. We should identify any background renal dysfunction, try to take a very good history, remove all the offending agents, do a good staging of the kidney disease, find out the cause, do a volume expansion, and in the critically ill population, better to go for 5% human albumin, do an individualized and response-guided approach, and can add crystalloids in these patients if the AKI is improving. We do not need to do anything further. However, if the AKI is persistent or progressing, which we can assess by urine output, we can do a bedside urine microscopy. And urine microscopy, if it's bland and consistent with HRS, we can initiate vasoconstrictor therapy, norepinephrine in the sicker population, and maybe terlipressin in the less sick. And if the urine microscopy is consistent with ATN or non-HRS AKI, then we need a lot of data, and we still do not have randomized controlled trials how we should be managing these patients. And I thank you for your very kind attention.
Dr. Kar, are you there? Dr. Kar, are you there?
Yeah. Now it's my pleasure to request Dr. Shiv Subhasrin, who is well known to the gastroenterology group as a whole, and who is the director of the Institute of Liver and Biliary Sciences. And to his credit, he has established one of the national centers for liver disease in this country. It will be a proud privilege to listen to him on prophylaxis portal hypertension, when and what. This is an important subject for all the practicing hepatologists to identify high-risk cirrhotics whom to put on prophylactic AVL or prophylactic drugs, this is needed to be heard from him. Thank you, Dr. Salim. Please give us the information.
Thank you, Dr. Carr. And thanks, INSL, for inviting me. Are my slides visible?
Yes, sir, they are.
Yeah. Yes.
Okay, it was nice to hear Rakhi, who works with me, but is always, excels the expectations. I bring greetings from ILBS, nothing to disclose, except that our students keep ranking second after AIMS Delhi. Now, prophylaxis means you don't have a disease, you only have the syndrome. I would like, therefore, it's a very good title, early, primary and primary prophylaxis. Early primary means you don't have varices and small varices. Primary is when you have large varices, they should not bleed. Can we prevent first decompensation? Can we prevent rebleed? And what happens in acute on chronic? And with what? ILBS, we see close to about 900 plus GI bleeds every year. This diagram is well known to you. This is like the blood pressure, 0 to 20. Normal is 5. 5 to 10 is subclinical. Although I will show you data, it is really not subclinical. 10 to 12, you start having clinically significant problems like ascites, varices, bleeds, gastropathy, hepatorenal, and others. Now, if the pressure is about 10, what will happen? If it becomes 12, 18, you have in 1 year decompensation. If your pressure is 24 HVPG, 20% chance of decompensation. Now, this is a very new data which Dr. Ankur Jindal had shown. If the pressure is about 20 HVPG or equal to 20, decompensation in 2 years will occur in about 40% of the patients. However, what is important is if the HVPG is between 6 and 11, even then you will have decompensation in about 15% of the patients. This is the key message, that cirrhosis, even with a pressure between 6 and 10, is a huge challenge, and we therefore need to move from liver to spleen. This is the data of less than 10. Now, if the pressure is between 6 and 8 and 9 and 10, what is the difference? Between 9 and 10, you may still have 20%, but if you have between 6 and 8, 6, 7, 8, you may still have 9% decompensation. Therefore, I would like to redefine clinically significant portal hypertension to be less than 8. This is quite revolutionary and is not being accepted by the editors. How do you treat portal hypertension? All what I am telling you is something new there, because rest all is known to such good experts. So vasoconstrictors increase, vasodilators decrease, and that's why you have high portal pressure. And the main drugs now are non-selective beta blockers, which block norepinephrine. Beta blockers can be used in pre-primary, means there is no varix or small varix. Carvedilol is useful. I'll show you this data. Prevention of decompensation, very little data. Prevention of first bleeding, yes, you all know it. Beta blockers will decrease. It's grade 1, level 1A. Rebleeding, yes, 1A. Here there can be a debate whether you can give band ligation or this. Gastric varix, very little evidence. Gastropathy, very little evidence, but we will still give. So all complications of rise in pressure can be managed. This study published a few years ago shows that from small varices to large varices, you can decrease the growth by reduction of only 8%. All of us were taught you need to decrease 20% portal pressure, but 8% good enough for small varices. This Predisky trial is to show you that patients who have got clinically significant portal hypertension, placebo versus beta blocker, especially those who are child's A, some of child's B, what happens to them? As you will see that there is no added advantage in patients who have a child Pu of 6 or so. Varices, no advantage. There is no advantage with different groups. However, when you take a comprehensive bleed or death, everything included, there is an advantage of beta blockers, and this advantage compared to placebo is still useful. This is the real life data. Very interesting data from Kang. This is non-selective versus giving non-selective beta blocker versus non-selective beta blocker. You will see there is definitely an advantage in probability of survival. Now you divide them into low dose versus high dose. You ask patient to take 40 milligram twice a day, long-acting Ciplar or propranolol, he doesn't take it. You ask him to take beta blockers, he doesn't take the carvedilol, or he just cannot be taken in, and I'll take this part. Now see the interesting part, low dose has a better survival than a high dose. And this is because many of your patients who cannot tolerate really should not be pushed further. Now let's look at primary prophylaxis. You are in a place where there is no HVPG, and this is just recent new guidelines. HVPG measurement available, not available. So if you're not available, just do the screening. And if there are varices, then you will definitely start carvedilol. If the pressure facility is available and you know the pressure is above 10, start carvedilol. However, some people do not respond. Their heart rate from 90 does not come below 70, or their blood pressure goes down. So what do you do? Then there is some new data to say that you can use Ivabret. It's a funny channel blocker. It specifically binds and reduces the diastolic depolarization. Not to go into details, you can add Ivabret to carvedilol. And this is the data which shows you that carvedilol plus Ivabret, you will have a much better advantage, as you can see here, in survival as compared to standard medical therapy. Not really too much from carvedilol. But here you have a group where you cannot decrease the heart rate. So you cannot use carvedilol. So the bottom line message is 10 milligram of Ivabret plus low dose of carvedilol improves survival. And achieving target heart rate is more important than beta blockade alone. Another drug which is very useful and many of us use regularly is metformin. Now this is 10 or more % reduction in HVPG. If you give metformin in a NASH cirrhosis patient, you will realize almost 60% of them achieve this reduction. And standard therapy, you do not. So carvedilol is metformin is a good drug in NASH cirrhosis. Endotherapy is very well known to you. I'm not going to detail. This is to show you that carvedilol and beta blockers, there is no major difference as far as prophylaxis. However, you have to choose your patient. All-cause mortality, however, is much less. Cumulative survival is better if you use carvedilol because this treats the cause. This study was therefore taken when Apurva, we were fortunate to have him work as a resident with us. This compares carvedilol, EVL, or a combination. Now here is carvedilol versus EVL. Carvedilol is this, EVL is green, and carvedilol plus EVL. So cumulative survival is much better when you have a combination of carvedilol and EVL and you compare it with carvedilol alone. So today in my mind, we must combine carvedilol and EVL. Here again, this slide shows you that carvedilol compared to carvedilol plus EVL has the best survival advantage. Here carvedilol plus EVL versus you have carvedilol alone. Can we do early tips in secondary prophylaxis? That was primary. I'm shifting to secondary. Secondary prophylaxis means preventing rebleed. So early tips is superior and it has an added advantage. So we recommend early tips, especially if pressures are high. So for secondary prophylaxis, you measure HVPG if available and give beta blockers plus EBL. Assess if it is possible. Avoid beta blockers, especially don't give very high, especially if systolic arterial pressure goes below 90, create goes up or sodium goes down. All such patients where you cannot increase beta blockers, please consider ready for a TIPS procedure. Now we have to see prophylaxis of portal hypertension, when and with what. This is a group of ACLF patients. In cirrhosis, you already have high pressure, 15, 20 of portal pressure. Then you get acute insult. In acute insults, liver cells die, cytokines released, stellate cells active, endothelium dysfunction, and vessels don't relax. So portal pressure further rises. This is one of the most important things I have learned in last at least 7-8 years. Sudden appearance of ascites, you touch the abdomen and portal pressure is 25, abdominal pressure is 25. These patients have ascites, they rapidly develop varices and they could actually get HRS and HE. And the reasons are many. Most important of them is hyperbilirubinemia in them. It's like bile in blood. They have poor heart function, huge vasodilation. Therefore, such patients with high cardiac output, rising HVPG require therapy. So can you give beta blockers for preventing complications of acute portal hypertension? We have always been discussing chronic. And this was the work which Sumit had done and published recently. Those patients who spontaneously decrease portal pressure or with beta blockers decrease, they have less varices progression compared to those in whom pressures are not decreased. Secondly, you will see that when you give beta blockers in ACLF patients, carvedilol compared to placebo, the 28-day survival is far better. Not 90 days because other complications come in. So in ACLF, reduction in pressure is more important than any other condition. Preemptive tips has been used here without tips, here preemptive tips. Survival has been shown to be better when you can do a preemptive tips and rebleeding rates are less. So this is my summary slide. Prophylaxis of portal hypertension is a method in which you can prevent growth of varices, variceal bleed. You can also prevent first decompensation. As I showed you, if the pressure is at 24, 20% 1 year decompensation, you can prevent it. You can prevent rebleed. You can prevent complications of ACLF. How? Carvedilol remains the choice, but if you have patient who have got huge ascites or low blood pressure or has kidney injury, then, and of course other contraindications, avoid. Bands are equally good, especially if your patient is a non-responder to beta blockers. And a combination of the two is the future. I would like to say the field of portal hypertension is very wide. Join it and enjoy it. Thank you for your attention.
Your lecture has been very informative and updated. I'd just like to ask you whether metformin is selective only for the NASH-related cirrhosis, or it can be used as a prophylactic for other causes of portal hypertension, you know? So,
Dr. Kar is a teacher of teachers, so it's a good question. Metformin is only, we have tried only in NASH cirrhosis, not in any other cirrhosis. And I can share that this was the thesis of Tanmay patients with a portal pressure of 20, 18. After 2 years, they have come down to 6 to 8. Fibrosis reduces, pressures reduce.
But do you think that because it reduces the portal pressure, I mean, the etiology has got anything to do with it, or irrespective of that, it should be also acting in other causes of portal hypertension?
I don't know that the main mechanism of certainly AMP kinase, and it is a best deactivator of stellate cell. There is a paper on this in both American Journal of Physiology and Gastroenterology, January 2018.
Thank you.
Thank you so much. All the talks were very lucid, and thanks to all the chairpersons for conducting this session. Now we move on to the orations, and for that I would like to invite the chairpersons. We have Professor Khuru from Kashmir, we have Dr. Manisha Bangar from Hyderabad, and Dr. Anil Arora from New Delhi. So may I request Dr. Manisha Bangar to start the proceedings for the oration.
Are you able to hear me? Am I audible? So good evening. Yes, am I audible, Dr.
Yeah,
Kaushik?
Manisha, we can hear you.
Yes.
Okay. Thank you so much. And a very good evening to everyone. It is my proud privilege to introduce and invite Dr. P.N. Rao for the presidential oration. Dr. P.N. Rao does not need any introduction, but let me tell you that Dr. P.N. Rao right now is the Chief of Hepatology, Asian Institute of Gastroenterology, Gachibowli, Hyderabad. And he's going to be enlightening us in his oration on NAFLD, how much do genes matter. This is a very new area, and I'm sure that we're going to all listen to it and enjoy it. Thank you so much. Over to Dr. P.N. Rao.
Thank you. Thank you very much, Dr. Manisha. I think let me share my screen. Yes, am I audible? And then my slides are seen.
Yes, they are.
Yeah, thank you very much. And well, I'm indebted to the Governing Council of Inasl for awarding me this oration because I find it as a privilege and also a pleasure to give this oration because it has given me a good opportunity to share some of our thoughts and work done in our institute with the genetics in NAFLD. I don't have anything to disclose. And we all know that the phenotypic description has started quite long ago about the NAFLD. And also now we are in the question whether it should be called an MAFLD or NAFLD. I shall not go into those kind of things because there is a separate session for that one. And then
I request everyone else to mute their mics.
Our mic is muted.
Right. Okay. As you can see here that what has happened was some kind of a GWAS revolution around 2008 when a PNPLA3 was discovered and the odds ratio of 303.24 in those people who have got a risk allele. And that has followed by other markers, other variants, out of which the transmembrane 6 superfamily 2 is one of the most important thing. And afterwards, again, GCKR, which will come a little bit later about what is the importance of these variants. In addition, on the right-hand panel, you are seeing that there is epigenetic variations are important and DNA variability, and there's been a lot of a gene-to-gene interaction, and also there are missense DNAs and then missense heritabilities, and then some of the rare variants are also there. And when you talk about the genetic predisposition in anything, non-alcoholic fatty liver disease or any other disease, what you need to have is first you must have a family aggregation studies, and then followed by twin studies, and then genome-wide and also exome-wide association studies that can and identify the candidate genes, and then finally come to a conclusion if a given gene or a mutation or an SNP is harmful or whether it is a helpful one. And I can see here on the left-hand side, the NAFLD assessed by the liver biopsy, MRS, or a ultrasound, and family-based twin studies. And you can see that the family aggregation studies, in the middle, the genetic studies, and the twin studies. On the right-hand panel, you are seeing the NAFLD assessed by the abdominal in the population-based studies, quite a large number here. And what is interesting to see is that the heritability varies from, as you can see here, that in fact, in the twin studies, the heritability, as expected, of course, about nearly up to 25%. In the family aggregation studies and also in the population studies also, it is interesting to see that heritability is up to the 25%. That means that this means definitely that the genes are important and they play a very good role in either the steatosis or a progression to cirrhosis and then hepatocellular carcinoma. And in 2016, when we reviewed, then we find that the PNPLA3 and the TMS6F2 and some of the other little bit not so important variants have been present. And the GCKR, of course, is important, but the rest of the things are not very important in terms of their association with the phenotypic status. But when you look at the 2020, some more have been added. I can see here that MBO87, HSD17B13, and other things. What I mean to say is that as we explore, more and more genes are going to come. And what we have to realize is that which are the ones which are closely associated with a loss of function or a gain of function in this particular field. Why the first two are very important because PNPLA3 and then transmembrane, you can see on the right-hand panel, PNPLA3 has been associated with the fat, NASH, fibrosis, SCC, mortality, and therapeutic response. And that's the reason why that is gained a lot of importance, both in the form of a steatosis and their progression, and also even malignancy. And TMSSF2, transmembrane superfamily, again has been associated with the most of the things. As you can see here that as you go down, the associations and then causing this one has been less and less. And suffice it, one thing I would like to say here there, HSD17B13 is one of the variants which is helpful and then which has reduced the NASH and then cirrhosis, which as we go along, we'll be able to see that. So what are the very important things? That PNPLA3, that is a patatin-like phospholipase domain containing protein 3, that it is in a lipid droplet modeling. Basically, these are associated with either lipid metabolism or a carbohydrate metabolism. We got the transmembrane 6 superfamily member 2, and that helps in the VLDL secretion leading to lipid accumulation. And we got a GCKR, that's a glucotoxicity. We know that is very important also, in addition to lipotoxicity, and that is the de novo lipogenesis and MBO80 membrane-bound acetyl transferase domain content. That's a remodeling the phosphatidyl stop. And why TMS6SF2 is important is that it's also been associated with the NAFLD, alcoholic liver disease, HCC, and we know that the variants, especially the PNPLA3 has been shown that in people who are having the risk variant, if they are alcoholics or even viral hepatitis, the risk of progression of the disease is more than who are having the regular wild variant. And this is one Dallas study, which was actually first initially, it was the 2008, the PNPLA3 was discovered. And what it means that you can see here that in the Dallas heart study, and those who are around the GG genotype has got the highest lipid content in their liver. And also, and we know that the African Americans are a low fat, and that is because they got a wide variety. And this kind of an ethnic differences do occur, and we have to go by regional differences rather than any of the global data. And as this is a good slide, as you can see here that the GG is a mutant variant which increases the liver fat, whereas the CC, although it is in the red engine, that is a useful, and in those people, sometimes we wonder, they were very obese people. They come and then their ALTs are only 15, 20, they're normal. They have a steatosis, but they do not have any evidence of a NASH, and persistently they do not have any kind of a hepatic injury. And this clearly shows that as your BMI is increasing, the hepatic triglyceride content increases, and consider cirrhosis risk. And in those people who have got a favorable, there's a wild variety, the risk is much less, even though they are putting on the weight, as compared to the people who have got a risk variant, there's a GG variant when the cirrhosis risk is. And ALT is also similarly explained here. And we have done the first one of the studies, earlier studies we have done, and in 2014, we looked at the pooled genetic analysis of the ultrasound measured non-alcoholic fatty liver disease. Is a pilot study in the Indian subject. Suffices for me to say that at that time, we concluded that the pooled genetic analysis revealed association of SNPs in the PNPLA3, which was also associated with the higher levels of an ALT and also high triglyceride levels. When we are analyzing our patient data, we found that those people with the Northeast Indian, those who come from the Northeast, and we compared we found that there was a significant difference in the ALT in the ancestral South Indians and also the Northeast Indians. We found that the ALTs were higher in the Northeast. Of course, one has to go into the details of the nutrition in these people, but we wanted to see whether is there any genetic differences in these people. And in addition to the PNPLA3, we have done the TM6SF2 because there's another one which is associated with the progression of the liver diseases. And in these two populations, and also PNPLA3, the variant is there, and another variant also has been looked into, which is associated with the lipid metabolism here. Suffice it for me to say that these are the differences which are seen. The PNPLA3, that's a standard which we know about. This is the variant. This is another variant. And in South Indians, we got an association with this and the TMSF, but in the North Indian, the TM6SF2 has not been found to be associated. Nevertheless, at least two of these are there in whether South Indian or a North Indian, but this needs to be further explored. And also we have to compare it with their nutritional, other microbiota and other data is still required. And PMT is another one, and this is PMT is an enzyme that is a phosphatidylcholine methyl transferase enzyme. 3 times it undergoes methylation, and it is responsible for the choline. And choline is an important one, as you can see here, that is responsible for excretion of the fat in the form of a VLDL, although it causes atherosclerosis, but the liver is good for the hepatologist. And it's been found out that the PMT-RS7946 was found to confer an enhanced risk. That means that because of this absence of this enzyme, the phosphatidylcholine is not formed, and therefore there is an enhanced risk of accumulation of the lipid in those people who have this variant. And when we are looking at the data, the GWAS data, we found that we looked into this in the lean NAFLD. As you know, that the lean NAFLD is an enigma, and then why they develop the disease in spite of being lean. And when we looked at this particular variant in the total NAFLD group, we did not find any significance, but in people within the lean NAFLD group, and this was found to be significant. And the other variant, the OSPPL10 has not been found to be significantly associated, and the variant in PMT, but not the other one gene, was associated with a 3-fold increase in the risk of NAFLD in the lean individuals. Well, so far we've been talking about the risk alleles. The ones there are some, as I said, some obese people, they come with a normal ALT and they do not progress to the liver disease at all. Is there any genetic background in these people? And there was a paper, and it has shown that a protein truncating variant, which is called the hepatic lipid doublet protein hydroxysteroid, some tongue twisting names, hydroxysteroid 17B dehydrogenase and HSD 17B13, was recently reported to reduce the risk of alcoholic and the non-alcoholic cirrhosis. And, um, and and this has been seen, as you see here, that it does not prevent any steatosis in the variant, but there is significant decrease in the fibrosis in those people who have this variant. And we just wanted to look at, in our people, what is this protective variant is present or not? And not only that, this variant, that is HSD17B13, has also been shown that it mitigates the effects of a PNPLA3. What it means is that PNPLA3 association increases, as we already said, it increases the ALT levels. And it's been found out that if this HSD17B13 is associated also with the PNPLA3, it mitigates the effects of a PNPLA3. That means that it reduces the ALT levels if it is associated with. But we did not find any association of this splice variant in the Indian ethnicity. And further, and then this is there in the poster accepted in this 221 today's this one. And what we did is that PNPLA3 and HSD17B3 wild compared with the risk variants, also we did not find any difference in these. So in our population, what has been shown as a kind of a protective variant, we have not found it. And the immunohistochemistry in these people, in all the three, whether it is a wild variety or whether it's a mutant variety, we found that it was equal. The fat has been there, and there's been an expression of the protein, but functionally it's not been. And another variant, MARC-C1 has also been found to give some kind of a protection here. Again, I'll come back to the phosphatidylcholine here, and these people, and there is an increased excretion of the phosphatidylcholine, and therefore that has been helpful. And as you can find here that steatosis has been the same, whether you have a risk allele, the variant or not, or a wild one, but definitely ballooning has been less, inflammation has been less, activity has been less, and even the soft score has been less, and there has been a significant fibrosis also has been less. That means that we have to look at that there are some variants, which are associated with a protection, that is a decreased formation of progression to the NASH and then cirrhosis of liver. Then let's see whether this non-invasive risk estimates of in the non-alcoholic steatosis, that is, whether you can say that whether you can estimate the risk. And people have done, along with the PNPLA3 only has been used in these, and they said that they have added some other parameters. I will not go into the details, and suffice it for me to say that addition has helped in these people, that is 82% probability in the presence of all the 4 risk factors. That means suffice it for me to say that if you add the PNPLA3 along with other factors, which they have used, and they found out that it is, you can predict the progression to cirrhosis in these people. Then does it help when you do a therapeutic intervention? Does it give a clue whether they are going to improve or not? And in this also, we have got some kind of a data where after bariatric surgery, what happens in those people who have got a PNPLA3 association, and in those who do not have any PNPLA3, and also lifestyle modifications also has been shown. And it's been shown that definitely one can predict by therapeutic interventions whether you have the risk. Those people who have got a carrying genes lost more weight, and also that's been helpful in these people. So some kind of the prediction is also possible by using the genetic data. But so far we've been saying only one gene, but people have done that one gene is not enough. You have to have the polygenes. That is the gene risk score ratio. That means combining many risks, as we know that the pathophysiology of NAFLD is not simple, and then it is a very complex, and therefore one gene is not going to be helpful either in the predicting or in the progression or finally in the therapeutic management. And therefore, people have looked at the genetic risk score and the clinical prediction of a hepatic steatosis in this group, and it's been found out that if you add more genes, as you can see here, that 3 has been added here: PNPLA3, TM6SF2, and GCKR, and other also. Addition of this has improved the predictability in non-alcoholic fatty liver disease. And also, there's been another paper which in the Canadian Journal which has shown that the combining the different disease-associated variants, and it will represent the way for the genetics to keep the strength of the NAFLD. That means if you add more genes, and then you can develop a score. And this is particularly to do a personalized management. And of course, genes is not all things. Environment is important. That is what I call it as a GEM: genes, environment, and the microbiosis. And we know the influence of the diet on the microbiota also, and therefore these are also equally important. And in our small study here, that we did not find any difference in the nutritional intake between the variant and then carriers, the variant carriers and the wild type of the genotype here. But definitely in those people who have got a variant carriers, the ALT and then AST were high. But we have to go into the details of a microbiota also to decide about what kind of an effect the nutrients will be having it. And this is, of course, gaining more and more importance, the nutrients and the microbiota in obesity and then NAFLD. And that's why people are going for a network kind of an analysis. That means artificial intelligence is going to take place. You're going to give a chip to the patient that's perhaps combining all everything. In fact, the metabolic syndrome parameters and the metabolic pathways, immune system, and everything. And that's what people are going ahead with this. And therefore, the so far for both are specific gene risk variants have now been robustly confirmed to exert a large impact on NAFLD, and it's been shown that the effect size is comparable to other metabolic diseases like obesity and diabetes. And this risk extends also into the progression and also liver-related mortality. Single gene variants are incapable of individual risk profiling, and therefore most attractive approach to date is the development of the polygenic risk scores. And genetic risk variants may be able to profile subset of the patients with a different pathophysiology and then response to the treatment. And therefore, time has now come to evaluate the efficacy, cost effectiveness of including the genotyping in the assessment of the non-alcoholic fatty liver disease. And this is the last slide, the genetic pathogenesis, and then at every cellular level, which genes are working. And suffice it for me to say, this is the work, this is the initial work, the pool genetic, stressing the importance of the PNPLA3, then the two different ethnicities is different, and then the lean NAFLD, PMT variant, and we did not find any association of the protective variant here, and we did not find any association with the metabolic syndrome, and HSD variant has not been found to be associated. Lastly, we also done the whole exome sequencing. What I said was not a biopsy based, but in about 28, in the 21 biopsy proven patients, we have shown that what all we have shown has been found when in the biopsy patients also. And these are the people who have been associated. And thank you very much for your interaction. Thank you.
Thank you, Dr. P.N. Rao, for the very, very lucid and a very illuminating talk. A very difficult arena, but still you made it so good and understandable. I would like to hand over the mic to Professor Kuru for the introduction of our next esteemed guest. on the presidential oration.
Thank you, Dr. Manisha. Am I audible?
Yes, you are very much audible, sir. Please go ahead.
Okay, thank you. Thank you, the family of INSL, for giving us an opportunity to chair this session, these two important events. And I have the pleasure and the pride to introduce Professor late Dharamveer Datta. It's a nostalgic moment for me. Professor Datta was one of the first hepatologists who set up a department of hepatology at the Postgraduate Institute of Medical Science and Research in Chandigarh. Professor Datta was born in 1934 in Gwalior, Madhya Pradesh, and he did his medical schooling and completed it in 1958 from GR Medical College, Gwalior, and then did his MD Medicine in Vikram University, 1961. He went to Royal Free Hospital and joined the team from Professor late Dam Sheila Sherlock, and did his PhD there in 1964, and went on to Harvard Medical School as a research fellow, and finally came and joined the PGI. That was in 1967. And over the next few years, he set up a department of hepatology in which many of us, including our president, Professor Rao, and me, and many others have benefited. Dr. Datta was an excellent researcher and with a very acute observation. And he set up a hemodynamic lab and a research lab in his department, and did excellent research on idiopathic portal hypertension and its etiology, Budd-Chiari syndrome, and Indian childhood cirrhosis. And he passed away in 1981. And in his memory, it's important that this society has set up a oration, and which is given today by a legendary hepatologist from US, Dr. Naga P. Chalasamy, who will be introduced by my friend, Professor Arora. Thank you for giving us this opportunity to chair this important oration.
Thank you, Professor Kuru. At the outset, I'm extremely thankful to Dr. Kaushal and Dr. Rao for having given me this opportunity of interacting with you. I have been given only 1.5 minutes to talk of a celebrated personality, Dr. Naga P. Chalasamy, and introduce him. So I have to be squeamish because it's so difficult to just sum up his achievements in 1.5 minutes. Professor Chalasamy is one of the most renowned hepatologists in the world who has been associated with National Institute of Health since 1999. To his credit, he has 3 UO1 and 1 R01 award from NIH. As of now, he has 260 original publications. He has written 3 clinical practice guidelines. He has authored 47 book chapters and has already published 39 editorial articles in the various journals. He had been regularly conducting the symposium and webinars on the field of both alcoholic and non-alcoholic liver disease, and his team has already submitted around 500 abstracts in hepatology journals. He has been the backbone of the basic research both in alcoholic and non-alcoholic liver disease, and presently he is working as Professor David W. Crabb, Professor of Gastroenterology and Hepatology at the Indiana University, where he is heading a team of 50 senior gastroenterologists. With that, I'll request Professor Naga Chalasamy to please deliver his talk on D.V. Datta Memorial Oration. Professor Naga Chalasamy, please.
Thank you, Dr. Arora, for the kind invitation. I hope you all can listen to me. Am I
Yeah, we
audible?
can. Yeah, you are audible.
Thank you
very much. Yeah.
This is truly a great privilege to be delivering this oration. I consider myself a third generation Indian hepatologist, and I hear Dr. Rao and Dr. Kuru were trained by Dr. Datta, and I actually a bit trained by Dr. Rao. When I was heading out to US in 1990, I had few months of GI training on Dr. Rao. That's actually my first research protocol was with you, Dr. Rao. So thanks to you. And I want to thank you and Dr. Kaushal Madan for inviting me to deliver this lecture. I'm going to start sharing my slides. Can you see my slides?
Not as yet. Yeah,
What about
got it.
now?
Yeah, visible now. Good.
Okay. Once again, really, this is a highlight of my career, and I'm incredibly thankful for the opportunity to speak about the risk of drug-induced liver injury in patients with chronic liver injury. Enjoyed some of the talks given by earlier speakers today. Many individuals have helped me to put this talk together from the academia, US FDA, NIH, and pharma, and I'm truly grateful. This is sort of an area that I've been investigating for about 15 to 20 years. Just to start with what Dr. Hy Zimmerman had said nearly now 40 years ago. Hy Zimmerman, as you know, is the father of hepatotoxicity. He said, a stubborn misconception regarding susceptibility to hepatic injury has been the view that patients with pre-existing liver disease are more likely than others to experience hepatic injury. However, he argues virtually no evidence except for, the C17 alkylated steroids and maybe rifampin. But I think, as you would see in my slides, this is way too simplified. I think it's far more complex. And then I'll shed some light on my thoughts in this area. And another pioneer in the field, Neil Kaplowitz, in 2018, had a personal communication with me. He said, I could dream up a lot of reasons why patients with chronic liver disease could be at high risk for idiosyncratic DILI. So the key issues when you deal with DILI in patients with chronic liver disease, number one, are individuals with chronic liver disease more susceptible to idiosyncratic DILI? We will touch on that. Second, I think all of us have an idea on this. If somebody with chronic liver disease or cirrhosis were to get DILI, are their outcomes worse? How do we actually adjudicate causality in a patient with cirrhosis who happens to take a medication when they get jaundice? Is it underlying liver disease that's gotten worse, or is it drug-induced liver injury? Finally, this is an area of great interest to me. How do you actually look for DILI potential in drug development, especially as compounds are being developed for non-alcoholic fatty liver disease and NASH? So when you think about patients with underlying liver disease, if there is a potential for increased susceptibility, a lot of factors to consider. First, as you look at the publications, first is how is DILI defined? I think over the course of last 30 years, the definitions have evolved. Second is what type of liver disease? Are we dealing with parenchymal liver disease or cholestatic liver disease? I think this is relevant in terms of the risk for DILI in patients with chronic liver disease. Are we dealing with acute or chronic DILI? Most of us, when we think about DILI, we think about acute hepatocellular, but I think there are the chronic forms of DILI. For example, there could be drug-induced NASH, there could be nodular regenerative hyperplasia. And then the severity of liver disease Are there instances where generally non-hepatotoxic agents become more hepatotoxic in chronic liver disease and cirrhosis? A thing comes up is, for example, rifampin. Is it more hepatotoxic in PBC, but not more so than general population? Another entity we recently observed is, for example, saroglitazar, which is sort of a compound from India, seems to be quite safe, no hepatotoxicity signal in patients with NAFLD, but in the trials done for PBC, there seems to be a DILI signal. So we are starting to see that a compound can just behave differently in PBC, but not so in NASH. I think there are nuances to this area. If you look at the literature, this is a paper from Jim Lewis and Jonathan Stein showing, or at least reported in the literature, to say that these compounds have an increased risk of hepatotoxicity in patients with underlying liver disease. I think to most part, the data are murky, but I think most of us would agree isoniazid is more risky in patients with underlying liver disease. Therefore, we all are hesitant to, for example, give it to patients with cirrhosis. And the tamoxifen, I think if you have NAFLD, if you give tamoxifen, I think there are convincing data, at least in some ethnic groups, for example, Japanese, there seems to be heightened risk of progression to NASH cirrhosis. There are other things written, shown here. Methotrexate, I think, is certainly more risky in patients with NAFLD, alcohol consumption, and obesity, hepatitis C. A widely quoted paper now, this is over 20 years ago, published in Hepatology. This is the paper that's cited to say that if you have underlying hepatitis B, and if you take anti-tuberculous treatment, there is about a 4-fold higher risk of DILI. Let me just walk you through this paper. There were 319 patients who received anti-tuberculous treatment. 43 were surface antigen positive, and 275 were not. And whereas they also had 86 patients with Hep B controls who did not receive anti-tuberculous treatment. And they showed that if you happen to have hepatitis B surface antigen and received anti-tuberculous treatment, they contended 35% had DILI. But the problem with this is DILI definition was 1.5 times upper limit of normal for ALT, which we don't accept today. Today's definition is 5-fold increase in ALT because there is just a background fluctuation for NAFLD, Hep B, and so forth. Another interesting thing that I'm just not so sure how this eluded the reviewers. Most episodes of ALT increases in this paper were associated with an increase in hepatitis B DNA levels. So to me, it seems like this is rather a flare of hepatitis B rather than anti-tuberculous drug-related liver injury. But nonetheless, this is one that's often cited. And then a lot of literature about underlying hepatitis C, viral hepatitis, and antiretroviral hepatotoxicity. Chronic Hep C is thought to be associated with about 2 to 5-fold increase in risk for heart DILI, and the same thing with hepatitis B. However, though, Ken Sherman and others have argued what we are seeing isn't necessarily DILI, but this is immune reconstitution. As you give antiretroviral therapy, there is immune reconstitution that may lead to increase in ALT. So this is a bit unsettled. So what's been written in the literature about hepatitis B, hepatitis C sort of increase the risk for DILI, I would say the data are mixed and not so convincing. And this is, I've already touched on tamoxifen, methotrexate. But what you see is for a lot of these compounds, these cause chronic DILI, where you have sort of a NAFLD type of picture and also progressive to NASH and even cirrhosis. Seems to be an obesity, seems to be a risk factor. Very interesting phenomena has emerged recently. There were 2 compounds from Eli Lilly. One is a glucagon receptor antagonist. The other one is peglispro. This is a long-acting pegylated insulin. In clinical trials, phase 3 clinical trials, both caused hepatic steatosis. Interestingly, PNPLA3 GG G allele seems to be a risk factor. So Dr. Rao has talked about many things PNPLA3 does, but it also seems to be related to drug-induced hepatic steatosis. And there are other data saying the same thing, that PNPLA3 may play a role in drug-induced hepatic steatosis. So now moving into some of the work that we've done to show that underlying liver disease may not be a risk factor. This is old news now, about 17 years ago, showing that patients with underlying liver disease taking statins, they are not at a higher risk for DILI. We are talking early 2000s. All of us were facing this fatty liver population. They had dyslipidemia. They needed statins, but at the time, the label, the package insert said, don't give statins to people with underlying liver disease. So this is a study where we have done to show that if you have increase in ALT, and if you got put on a statin, your risk of DILI is no higher than liver disease controls who are not put on a statin. And this study was followed, I suspect, by about a dozen follow-up studies consistently have shown different statins, including Dr. Vipulanchi has done study with lovastatin, fluvastatin, so forth, showing the same thing. Statins are no more hepatotoxic in patients with underlying liver disease. A similar study we have done with rosiglitazone showing that this was because you remember troglitazone, the parent TZD, was associated with drug hepatotoxicity. When rosiglitazone came into market, there was a lot of concern if it was going to cause the same thing. Here we were able to show that if you have elevated ALT and if you were given rosiglitazone, there is no increased risk for drug-induced liver injury. As a matter of fact, there was actually improvement, as one would suspect from TZDs in patients with NAFLD. So that's the work we have done to show there is not heightened risk for DILI, at least from statins and TZDs. This is a paper that we just published 2 years ago in CGH. Craig Lambert from IU is the first author. Let me just walk you through this. Our hypothesis was that if you have underlying liver disease, and if you are given common hepatotoxic agents, you're not at a higher risk for DILI, like all of us believe, right? So we have done, using Indiana Health Information Exchange, we constructed a chronic liver disease cohort based on ALT, and these patients did not have Hep B, Hep C, did not have heavy alcohol consumption or hypotension. This group was about 25,000 people. And then we constructed two control groups. One control group had ALT less than 45, other control group had ALT less than 31 in men and less than 19 in women. And really a large sample size here, over 200,000 individuals. And we defined suspected DILI using sort of standard criteria. But we looked at 10 common agents, for example, like nitrofurantoin, Bactrim, augmentin, amoxicillin, clavulanic acid, and so on and so forth. So our study was to look at DILI within 3 months after any of these compounds were given to either patients with chronic liver disease or this control group. So what you saw is in the middle column here is sort of bolded here. If you have underlying liver disease and if you received one of these 10 compounds, the risk of DILI was 2.1%. This was surprisingly significantly higher than either control group 1 or control group 2. This was actually disproving our null hypothesis. We assumed this would be the same based on some of the statin work we have done. So the odds ratio was about 6 to 7%. And what's so interesting, I think, is to sort of validates our observation is that patients who had DILI in the underlying CLD group had worse outcomes, whether requiring transplant or death. This sort of plays into what we know. If you have underlying liver disease and if you get DILI, you're more likely to have worse outcomes. This was a big surprise to me. And this was just published from Korea, basically validating what just we have shown. They have a large database using sort of similar to NHANES in the US. This is the National Health Insurance Service, national sample cohort, about 1 million participants. They looked at DILI, NAFLD. They basically concluded that the risk of DILI and NAFLD is significantly higher once the NAFLD diagnosis is made, about the same odds ratios as what we have found. But incident relative risk is about 7.7. And finally, this is a study that's published about 15 years ago, an Italian study in a tertiary care center showing the same thing in a prospective study, that the NAFLD was associated with a risk of DILI about fourfold. All these studies, I think these are epidemiological. I wouldn't cause these are definitive studies, but nonetheless, multiple studies are suggesting that if you have NAFLD, there may be a heightened risk for drug-induced hepatotoxicity. This is important because we have a lot of patients with NAFLD and then also a lot of clinical trials ongoing in this area. Not a surprise, patients with NAFLD have multiple reasons why they could have hepatotoxicity. There is increased reactive oxygen species. There is increased endotoxin, ER stress, and we know mitochondrial dysfunction, which is really important for drug hepatotoxicity. And then, of course, altered cytochrome P450 as well as drug transporters. Dr. Puri touched on altered, cytochrome P450 in patients with diabetes and cirrhosis. Same thing sort of happens in patients with NAFLD. This is a paper that was published by Rajbu Palanchi showing NAFLD has profound effect on hepatic cytochrome P453A. Of all cytochrome P450s, 3A is the big kahuna. This is the one that metabolizes about 50% of xenobiotics. Why is that important? If its activity is down, your levels are going to be high. Therefore, the concentration of the parent compound is going to be much higher. I will show to you that the concentration, the exposure is becoming very important risk factor for DILI. And these are unpublished data from our own lab showing that this is an RNA-seq study in about 150 patients with liver biopsies where we have done the RNA-seq on liver tissue, showing that based on NAFLD activity score as well as fibrosis, there are profound changes in pharmacogenes. This is based on NAFLD activity score. This is based on fibrosis showing that NAFLD, there's just a tremendous changes in drug disposition. This is important because this may increase exposure to compounds. For example, if you have significant NAFLD, and if you have taken a statin, your parent compound concentration can be significantly higher. That may therefore cause hepatotoxicity. This is a study actually from our own group. First time I think about Ravi Jaluri was a fellow at the time. We were doing a study with salicylate to improve endothelial dysfunction in HIV patients. To our surprise, 4 out of 11 patients had significant elevations in ALT, in the order of 500 in some patients. That's about 10 times higher. To our surprise, the increase in this ALT was tightly related to salicylate blood levels. So this is the first time we started to put pieces together to say that the concentration of a compound is related to drug hepatotoxicity. And then these are direct-acting antiviral agents and risk for drug hepatotoxicity, Vicurapac, and Puritabravir, Zapatir, all these have shown the same thing. They are not hepatotoxic in chronic hepatitis C, but as you have advanced liver disease, they become hepatotoxic. Not only that, their concentrations are dramatically increased. For example, Puritabravir, if you're given to patients with child C cirrhosis, look at the exposure is increased by 1,000%. That's almost like you're taking 1,000 times the dose of this compound if you have child C. Really big deal. Obeticholic acid, it's a popular drug. I believe it's approved in India for NASH. It is associated with hepatotoxicity. More importantly, cholestatic type of hepatotoxicity especially given to patients with underlying liver disease. So dose adjustment is really critical. If you are giving this to a cirrhotic, a NASH is cirrhotic, dosage has to be under 5 milligrams. But mind you, the efficacy in NASH trials was at 25 milligrams. So be cautious when you give it. Another lesson from obeticholic acid post-marketing experiences, even the cholestatic injury, things that we previously didn't think would be fatal, now we know that can cause fatal outcomes in patients with liver disease. Do I still have another 5-10 minutes, Dr. Arora? The clock is winding down.
Sure, sir. You can take another 3 to 4 minutes.
Thank you so much. So just moving on to DILI, what happens to patients with underlying liver disease when they get DILI? This is a paper from US Drug-Induced Liver Injury Network showing that there is about a 3-fold higher risk for dying. Not a surprise, but this is the first paper to document. This is a paper Marwan Gabriel from our institution has published in Gastro a couple of years ago showing if you have DILI and if you have underlying liver disease, your odds ratio to die within 6 months is about 5-fold. And Andrade's group has shown the same thing. This is a paper published, I think, within last 6 months or so in Journal of Hepatology showing that if you have underlying liver disease and if you have DILI, the risk of dying is once again about 3 to 4-fold higher. All these sort of things confirm what we've long suspected, that if you get DILI in the background of underlying liver disease, you're just not going to do well. It's not a rocket science, but this is sort of proving what we have suspected for a length of time. Just sort of touching on how pharmaceutical industry looks for compounds with hepatotoxic potential. They look at in vitro a number of things. They have written here a lot of different criteria. What I want to highlight is that this is a crapshoot. There are studies to show each of these criteria have high predictive value, but there are equally number of studies showing that they're not good. So industry does all this, but overall the sense is that they're good they're highly sensitive, but they're not specific. In other words, they're going to call a compound in vitro before first in human studies that this may have hepatotoxic potential, but oftentimes it's a false positive signal. What does that mean? That pharma is not able to pursue compounds, otherwise they have great potential. How do they do it? So the way it works is, first they do screening for small molecules, thousands of molecules. They have these chemical libraries using against a target. They screen for thousands of molecules, then identify some exciting molecules, and they do this in silico modeling. You know, Dr. Rao was touching on artificial intelligence. That's really what you're doing here to say, based on what we know, based on the compound characteristics, is this compound going to be hepatotoxic? And then if it is not, then you do in vitro assessment based on the criteria that I just alluded to. Then you do toxicology, animal studies. An area that I've said though is if you have a compound that you're developing for NAFLD, if you're doing in vivo or in vitro, perhaps you want to just not study normal animals, not normal rats and rabbits and dogs, but you may actually want to give it to generate fatty liver, because we know, as I said, the drug disposition is very different in patients with fatty liver compared to normal individuals. Just a slide on causality adjudication. You know, we use these instruments called the RUCAM for adjudicating whether a compound is hepatotoxic, whether the relationship between a compound and a DILI event. But the RUCAM instrument we just have no idea if it works in patients with chronic liver disease. I've shown here, this RUCAM is based on 7 domains. You know, each of these domains can be problematic in patients with underlying liver disease. So bottom line, I don't think in clinical practice you're using this instrument, but some of us doing research we do use these instruments for causality in patients with underlying liver disease. This just, we don't know whether it works. So to sort of conclude my talk, data are starting to suggest that underlying NAFLD may be a risk factor for DILI. More studies are needed, but I just urge caution with attributing, accepting what we're publishing as a fact, because these are epidemiological studies, just a lot of noise, a lot of imprecision there. I'd like to highlight two things. One, I think, is the concentration. The dose of a compound you give matters for DILI, especially in patients with underlying liver disease, because as being highlighted, drug disposition is altered, and a compound, if you're given 10 milligrams of statin, it may behave like a 40 milligrams of statin, especially when you have Child's class B and Child's class C. So you have to be careful about the dose. And the third is that the cholestatic DILI, for longest time, which we did not think is a big deal, if you have underlying liver disease, that is a big deal. That can kill your patients. And just the DILI and chronic liver disease is really a big hurdle for drug development, especially for NASH, PBC, and cirrhosis. That concludes my talk. And once again, I want to thank you for the kind invitation and for your attention.
Thank you. I'm sure all of you will agree with me that we had two very important talks in this session. The first talk was of Professor P.N. Rao, who talked about the evolving role of genes in non-alcoholic fatty liver disease, and excellent exposition of the subject. And thank you, Dr. Jalasani, for giving a brilliant talk on a clinical relationship of DILI and chronic liver disease as importance. With these two talks, two important talks, I think we come to the conclusion of this session, and I thank two of my co-chairpersons, Dr. Manisha and Dr. Anil Arora, for joining me in this session. Thank you very much.
Thank you.
Thank you, sir.
Thank you so much, Dr. Kuru, Dr. Arora, and Dr. Manisha. And thanks to both the orators for the brilliant presentation they made. So now we are moving on to a very interesting session. We have two very interesting debates here. So for this session, let me invite the chairpersons, Dr. Eapen, Dr. Mahesh Goenka, and Dr. Piyush Ranjan. So Dr. Eapen, kindly start the session.
Thank you, Kaushal. We are on to, as Kaushal mentioned, a very interesting debate sessions now. And may I invite the first speaker to speak on the topic. The topic is hepatic venous outflow tract obstruction. Liver transplantation is a treatment of choice. And to debate for the motion is Dr. Vinayendra Pamecha. Dr. Pamecha is the head of the liver transplant and HPB surgery services at the ILBS of New Delhi. Over to you, Dr. Pamecha.
Thank you very much, Professor Eapen. Can you hear me? Am I audible?
Yes, you are.
Yeah, okay. So thank you very much, Professor Rao and Kaushal, for the invitation and the whole Inasl team. This is an interesting topic, and I've been pitched against one of the pioneers of doing work in the country on HVOTO. So I think it's going to be difficult to defend for me, but let's see how it progresses. So yeah, so HVOTO is obstruction at any site, which is basically from small hepatic venues up to the IVC, and it's because of various heterogeneous etiology. It can be because of thrombosis, because of IVC webs, or compression due to abscesses, cyst, or cancer as well. And there is a very lot of varied presentation from hepatic fulminant liver failure to compensated chronic liver disease to decompensation and development of HCC. So the presentation can be very varied in different patients. And there are different risk factors associated with it, like myeloproliferative neoplasm or paroxysmal nocturnal hemoglobinuria or Beckett disease or liver diseases. So it's a very heterogeneous disease with a varied presentation. And so obviously the treatment is going to be a bit individualized rather than having a one set of treatment for a particular patient. So why liver transplant should be the choice of treatment in HPOTO? So it can take care of blockage at all the levels, that is from starting from small hepatic venules to the IVC. It can take care of all the presentation, that is an acute presentation to fluoride decompensation. It can take care of damaged liver parenchyma. It can take care of the HCC and also can prevent the development of hepatocellular carcinoma in the future. And liver transplantation can cure various etiologies like antithrombin 3, protein C, and S deficiencies as well. So that's why liver transplantation actually becomes a favorable treatment in HPOTO as well. So coming to data of liver transplantation in Budcari, so this is the full data actually, and you can see all the numbers are actually small, but most of these patients were transplanted for advanced cirrhosis or acute liver failure. And almost 1/4 of this patient actually had some sort of shunt done before transplantation. And there's a good median follow-up in all these series actually. And the 5-year survival actually goes up to 80 to 90%, and 10-year survival reaches at 70%. So these are patients who have been transplanted for advanced cirrhosis or acute liver failures. And you can see there is good survival achievable with liver transplantation. This is again data from European multi-center study of nearly 250 patients, and it showed that you can achieve 70% survival at 10 years. And what they said was the liver transplantation is an effective treatment irrespective of underlying cause. Renal function was the most important prognostic factor for liver transplantation. And alternatives to liver transplantation should not be persuaded up to the stage where patient develop renal impairment. And shunt does complicate the subsequent liver transplantation as well. So in multivariate analysis, the two most important factors which were found to have prognostic impact after liver transplantation was renal failure and surgical shunt or TIPS actually. So we should not be pushing the patient to the limit there, that their survival from liver transplantation gets affected as well. So unfortunately, we don't have head-to-head comparison of the data in the literature. So I tried to just put two very important papers on this. One was the paper which was published in Hepatology in 2004. What they did was they divided the patient according to class, depending on encephalopathy, ascites, ProTime, and bilirubin in class 1, 2, and 3. So in class 1 and 2, the survival was 89% and 74%, but in class 3, the survival was only 42%. And then there was another paper which was published in Journal of Hepatology in 2006, which showed 68% 10-year survival in 248 patients. And most of these patients actually were in class 3. So there is a very good long-term survival achievable in class 3 patients. So when we compare head-to-head patient-wise, liver transplantation does significantly outscores compared to other modalities of treatment. So these are the survival curves from those two studies. You can see class 1, it is good with conservative treatment or intervention treatment. But once the patient is in class 2 or class 3, then the survival actually decreases. You can see here 60% survival in class 2 and then 40% survival in class 3. Whereas with liver transplantation, it's almost 70%, and most of these patients were actually in class 3. Coming to acute presentation of HUTO, and without transplant, the in-hospital mortality is about 60%. If TIPS is done, the survival is around 38%. And eventually, most of these patients will actually require liver transplantation. And the contraindication to transplantation will be malignancy, or they're too sick to transplant. But with transplant, this is the recent paper published in American Journal of Transplantation. 55 patients, the overall mortality was 28%, out of which the waitlist mortality was nearly 20%. And the survival at 1, 5, and 10 years was almost going upwards of 70%. So that's a very good survival, long-term survival achievable in this sicker group of patient as well. And even in the presence of multi-organ failure, survival was very good with liver transplantation. So that what I'm trying to say here is even in sicker patient and with severe disease, liver transplantation achieves a very good survival, long-term survival in this group of patient. Now, when we see what is the current management policy of HVOTO, so what has happened is this is the step-up approach which has come up, which starts with anticoagulation, which may be effective in about 20-30% of patient. Then it goes up to angioplasty, stenting, and IVC plasty as well. Again, this is found to be effective in 20-30% of the patient. And then some of this patient will go on to have TIPS as well. And if TIPS is not done, then the survival is 45%, but TIPS, the survival actually reaches 71%. And if all these fail, then the transplant is offered, which is very actually irrelevant in the current context. And all this, step-up approach is not based on any randomized controlled trial. This is meta-analysis of retrospective studies, and the management, you can't actually apply same management algorithm to all the patient in current scientific era. So you have to individualize patients. And this approach is basically based on response to prior therapy, which is again denying patient and a better option, because you're just looking whether the patient is going to respond to a particular therapy or not, and then you offer a better treatment. That becomes irrelevant actually in this context. So coming to Sir's own paper, Sir has published extensively on this, and this is their data. So this was the first paper, I think, published in 2017, nearly more than 350 patients, out of which 25 were excluded because of some reasons. Majority of these patients were in child A or B. Endovascular procedure was not feasible in 98 of this. And in 32% patient cannot be benefited with endovascular procedures. And nearly 34% of this patient were lost to follow-up on second follow-up. So we don't have a very clear data in terms of long-term outcome from their own data. And then they also developed a score which was based on response to therapy and child class as well. And what they showed was once the patient is in the class 3, again the survival is dramatically reduced in this group of patients. So it's basically once a patient develops severe disease, then all the intervention treatment actually doesn't really help. So coming to what I interpret from that is endovascular treatment, not significant impact on survival in CTP C group, and in CTP A and B, 30 to 40%, the endovascular treatment was not feasible actually. So there is a lot of patients who are being actually trailed into or denied a better treatment by this step-up approach. Then they published on long-term outcome of endovascular intervention. This was 760 patients, a big denominator there. But out of this, 250 patients were excluded. So a huge chunk of patients are not there for analysis. Then out of that, 510 patients actually underwent endovascular intervention. 10% got lost in 1 month as well, or got lost in follow-up at 1 month itself. Then the restenosis rate was 20% and a mortality of around 11%, and the major complication was around 2.8%. So the overall probability of survival was 85%. But when we start with the denominator as an intention to treat analysis, and when we look at this carefully, the endovascular intervention was feasible, although they're saying 95%, but the actual feasibility comes down to 62%. That will be the intention to treat analysis in this group of patients. That's how the data should be looked into. And then when they analyze based on the type of procedure being done, whether it was just a revascularization, that is angioplasty, or IVC plasty, or whether the TIPS was combined. So whenever the TIPS was combined, that is the patient who need both hepatic vein and IVC to be dealt with, the survival probability actually came down, and there was a higher mortality associated with TIPS as well. So now what has happened is people have actually derived a lot of prognostic score in order to see how this group of patients behave. And if you look at this probabilities of sensitivity and specificity, they are both very low according to all these prognostic scores which have been tabulated here. So they are just in their 70s. So I don't think this is a good idea to treat patient based on sensitivity and specificity of 70%. And then people have tried to draw the ROC curves as well. And again, you can see the ROC curves for prognostication, both for invasive therapy and for liver transplantation. They are both poor as well. So all this prognostic criteria which have been derived, it seems they don't really work in this group of patient. They're not really helping this group of patient in terms of individualizing the treatment here. So although these prognostic scores are useful for clinical studies, but their validity is not proven for individual management. And we all know that MELD score, they are so poor, prognostic scores are so poor because they don't really deal with what actually happens to the patient. You can see this is a patient with MELD of 14 and severe sarcopenia, massive ascites, refractory ascites and all. So they are not really calculated into the prognostic scores. Then coming to head-to-head in terms of tips pre-transplant. So this was the paper which was published from Italy. And in this patient, again, they tried to compare the patient who had tips before transplant and patient who didn't have tips before the transplant. So again, 43 were excluded because of no tips because of technical reason. They were insufficient record. Then the waitlist mortality, when the patient were listed, there was no change in waitlist mortality. It remained same. So steps actually didn't really change in terms of the patient dying on the list. Although I agree that in this group as well, the patient did come out of waiting list, but once a patient was listed for OLT, it didn't change the waitlist mortality. What TIPS actually did was there were more hospitalization because of encephalopathy, and overall survival actually, although it was not significant, but you can see the numbers are there. It was lesser than the patient who are having upfront transplantation. So TIPS before OLT leads to higher preoperative admissions because of HE, and TIPS does not really change the waitlist mortality. So recanalization and stent, one of the most important thing about is in HUTO is about hepatocellular carcinoma, which is in the pool prevalence is about nearly 16%. And if you have an IVC obstruction, actually it goes up to 26%. So you can't really prevent development of hepatocellular carcinoma with intervention therapies. And actually the risk in this particular group is higher. And we all have dealt with patients who comes with nodular livers in Butkari, and then it becomes very difficult to diagnose HCC and actually to treat HCC in this group of patients as well. And overall survival, once they develop HCC, is poorer than the ones who doesn't have HCC. So that is again a group of patients who is disbenefited from intervention therapies. So in summary, I will say liver transplantation is the treatment of choice in patient with HUTO, especially in patient with advanced disease, acute presentation and HCC, and should not be considered as a last resort. The current step-up approach is not very evidence-based and have bias towards intervention treatment and may deprive patient the advantages of liver transplantation. Thank you very much.
Thank you. Can I now introduce the next speaker, who is none other than Dr. Acharya himself, Dr. S. Subrata Acharya. We all know him for decades now. And he is presently the Pro-Chancellor of KITS University in Bhubaneswar and was formerly the head of the Department of All India Institute Gastroenterology Department. Professor Acharya, please.
Thank you. Thank you, Dr. Goenka. Thank you for the introduction. And let me share my slides first. I don't want to debate with Dr. Kamecha. I think in hepatic venous outflow tract obstruction presents in a fashion in a various stages, and it is quite heterogeneous. There are a complete wide spectrum of the disease, starting from asymptomatic to acute liver failure and advanced stage cirrhosis. In any disease, when the liver disease is very advanced and almost end stage, no therapy, irrespective of etiology, works, and therefore transplant is there. If you see hepatitis B or hepatitis C or even alcoholic liver disease, there is no head-to-head comparison at various stages with conservative management and liver transplant. Liver transplant, therefore, in such diseases are based on prognostic scores like MELD or CTP, indicating those who have end stage, who are unlikely to reverse, need new liver. Now, if you see hepatic venous outflow tract obstruction, I will just come to that. Now, these first three sentences, if you see, the indication of transplant, it is end-stage liver disease, and I will show you data that hepatic venous outflow tract obstruction which presents with ascites, distended veins, or even varices are not indeed end-stage liver disease, and most of them, therefore, can be treated in different fashion other than transplant. Now, the end-stage liver disease where transplant indication is based on MELD or Child-Pugh score based on 3 months survival, of course, barring ALF and cholestatic liver disease, which is a different prognostic score, right, is not applicable in this group of patients, as Dr. Pamecha himself told, and very low specificity and sensitivity. Third question, whether before you transplant, each of you asked, whether adequate medical and other surgical therapy has been unsuccessful in providing improvement or reversing the element, and whether you can treat the therapy for etiology. These are three basic perception or basic contention based on which you decide on transplant. Now, if you see, this study was being quoted, but he quoted the portion, Dr. Pamecha, which suits you. Now, if you see, this is a large study, one of the largest cohort, if you have reviewed Dr. Pamecha, it is the largest cohort published probably till date, right, where these are continuous patients. And if you see in this group of patients, if you see they're young, they're unlike cirrhotics. Liver transplant is not a cure, it is a swab. You are giving them a lifelong immunosuppression, and liver transplant has post-operative, immediate, and late complications, which I need not explain further. Now, if you see, they present with ascites in majority of patients, and features of liver failure is practically absent. Out of these 421 patients, we had one fulminant Budd-Chiari patients. And if we evaluated further them, if you see 38% had cirrhosis, but many of them did well, better with major management, and most patients, 60%, didn't have cirrhosis. And the specificity for a liver-specific score, which is used for transplant, is quite low. So this is a different disease and should not be considered like end-stage cirrhosis. And I think everybody must have seen that this patient mimics cirrhosis, but are treatable without transplant in most. I will present the data. These are two patients I am showing. One was referred as SCC and one is referred as cirrhosis with advanced cirrhosis. And both of them with long-term treatment, particularly with endovascular shunts and tips, are surviving and did very well. Now, what are the treatment for hepatic venous outflow tract obstruction? I agree with Dr. Pamecha. There is no head-to-head comparison between various trials. Because this patient, when they present, they are heterogeneous. To randomize them, you have to homogenize them as far as the site of block, the extent of block, the presence of degree of collateral, the degree of liver functions, and presence and absence of procoagulation factors. It's very difficult to stratify them and uniformly match them. Therefore, it is not possible to do a head-to-head RCT amongst very heterogeneous groups. And that's the reason world over, people believe stepwise management. Because RCT between two similar groups will give you the results of intervention. RCT between a heterogeneous group is very difficult to give you results. Now we know the anticoagulations, photosystemic shunt, and catheter-guided angiological intervention, that is angioplasty with stenting or without stenting, and TIPS. TIPS, and lastly, the liver transplant. Let us see this, how they fare. Now, if you see the degree of, as I was telling, the site of blocks can be different from IVC focal to long stenosis, hepatic vein focal to long completely diffuse block, as well as both IVC and hepatic vein block with various degree of segment. The duration of obstruction is also different, and therefore the degree of congestion and duration of hepatic insult because of congestion is also varied. Those who have long-standing congestion has advanced fibrosis or cirrhosis with hepatocyte loss and hepatic features of frank hepatic failure. Now, obviously, all patients in this group has been recommended anticoagulation, whether you do transplant, whether you do angiographic intervention, because the re-stenosis or reblockage rates in this group patients are very high. So anticoagulation is for all patients. And most patients can be managed with endovascular intervention, depending upon the degree of a site of obstruction, length of narrowing, and success of technical process, technical procedure. The shunt is out. Shunt is nowhere performed in that. In fact, in a head-to-head comparison between shunt and angiography, you can see the difference in survival. So no more shunt is done probably as a first-line procedure. I will give you a data which Dr. Pamecha presented one single paper. All these papers since 1990s, in 79 publications, more than 30,000 cases has been subjected to a systematic review and was published recently. And this gentleman has published a book on Budd-Chiari syndrome, giving all areas. And if you see, he collected all these patients and he has summarized the data. And I have provided the 5-year survival data of all these patients. Let me tell that many patients who have been, many studies who have done liver transplant actually has not differentiated between those who have transplanted with excellent liver function and those who have transplanted with bad liver functions. And that is a very important stratification even amongst the treatment of transplanted group. And since it's a stepwise approach and everybody all over the world is convinced that anticoagulation with angiographic intervention is probably the first line treatment, if you see the registries, this is less than 0.5 to 1% of the total transplant that is being done. Now, Dr. Pamecha presented this paper. In this paper, we asked 4 questions to evaluate the technical success and complication of radiological intervention out of total patients, to assess the long-term survival and see who are doing bad. Can you identify them so that they can be subsequently transplanted in whom they are needed? And this is not a small number of patients. You can see we have to exclude patients because of the reasons which I have mentioned there. There is no point in including these patients. If you see, technical success was 91% by interventional radiology. And exactly similar study was published. This is a recent study from China, where the technical success was also 91%. This is a large study from China. And if you see, in most patients, we get away without doing a TIPS. And TIPS is necessary. In this, our study, about 20% simple angioplastic intervention with stent placement could be done and successfully done in 80%, cutting down the cost. And so also similar experience with the Chinese study, which are large study. That's why I have quoted these large studies. and very important, consecutive patients. Now, if you see the response rate is response of improvement of the liver failure or liver function, restenosis rate, mortality rate, right, over a long period of follow-up. And if I see, I don't deny that there is a mortality of 20%, and there was a procedure-related death of 0.85% in comparison to 5 to 15% of mortality in transplant. There was restenosis rate in about quarter, but they can be redone all. And if you see further that we had a group of patients who didn't undergo the intervention, since simultaneously they either could not be subjected to intervention or their technical failures. We compare these two groups, and if you see the response rate with endovascular intervention in comparison to medical management is markedly and significantly better, and failure rate is much less. Because we had two groups, we could evaluate the prognostic scores. And first thing I want to say and agree with Dr. Pamecha, that at the time of presentation and intervention, the child's status determines not only success, also long-term survival. It's very clear. Better good liver function, easy endovascular intervention, better response. And I have shown that 60 to 70% of our patients do not have cirrhosis, has hepatic congestion and ascites in a large continuous cohort of patients. And hence, most of them can be treated with endovascular intervention. If you see separately, the survival with successful endovascular intervention and incomplete or failure, the 5-year survival is markedly different. So there are two things. One is the stage of the liver disease and success of the transplant. But if you see the success of transplant, success of the endovascular intervention across the child's criteria has shown if it is successful, 5-year survival is markedly better, even in child C group. And they improve. And therefore, and if I evaluate tips separate, I've shown you the results of tips separate, that our cumulative patency rate at 5 years was more than 80%. Hepatic encephalopathy free survival was more than 84%. And if you see overall survival at 1 year 93 and 5 year 84%, it is much higher in those with complete responder, but not with the responders. And obviously this should give us a guideline how to manage them. We went away and we indeed found in multivariate analysis, child's as well as response to intervention or successful intervention are the two important determinant or independent predictor of survival. And we could develop a discriminant score on this. Taking their odds ratio and beta integer. This is a very simple score. Response complete 1, incomplete 2, no response 3. Child's A 1, B 2, B C 3. And simple, the score was 1.2 into response, 1, 2, 3, 0 point into child class, 1, 2, 3. See the result. Those with a score of less than 3 are 95% 5 years ago. Can it be better than score? Even score between 3.1 to 4 has 85% 5-year survival. Only patients with score more than 4 has a 5-year survival of 40%. This is the group where you need probably liver transplant, and we have to see the result. And this is what exactly I just told. We compare to the established score. I agree with Dr. Pamecha, MELD CTP are not right scores. And Rotterdam BCS and BCS tips were scores developed long back. Rotterdam BCS didn't include the intervention. BCS include the intervention. Since endovascular stenting is very important, therefore, a prognostic score is needed following endovascular intervention to decide who needs select transplant. And that is why the stepwise approach is much more beneficial, will be less expensive, and all patients will not need immunosuppression lifelong with post-transplant complication and regular follow-up. Here, we have to follow up with anticoagulation and repeated ultrasound Doppler to see stent patency. When the stent pet is blocked, you can correct it.
Sir, you have the last 1 minute.
Yeah, hope this is finishing. This is a European multicentric trial. If you see the same thing they found, this is another part of the world. If you see the endovascular intervention, 5 years survival, very good. And all these patients who has failed endovascular intervention subjected to OLT has a good survival. So if you combine them, the survival can reach 95 to 96% if you use a stepwise approach. And that's why exactly this is the LR I have given. And recently, what I told, the first step is to try anticoagulation with endovascular intervention, depending upon the site and extent of block. If they fail, and according to the prognostic marker, then you have to do a transplant. This is the APSL guideline, which has been given, recently published by Dr. Akash Shukla, exactly similar guideline, which was published in 2021. So in summary, I will say, all patients with hepatic venous tract obstruction should be managed in a stepwise manner. I'm not contesting transplant or medical management. There is no head-to-head comparison of all form of therapy. I agree. We need anticoagulation for all. Radiological intervention, as I have shown, one of the largest data and data from China as well as from Europe, it should be the mainstay of therapy with excellent long-term result and survival, less expensive than transplant, do not need immunosuppression, do not have all the complications of post-transplant, which you all know. Even if there is a restenosis, it can be treated. Post-intervention follow-up with assessment of prognostic score to select patient for transplant is important. And out of total 100 patients, I will think 10% or so will need transplant and 90% can be treated without a liver transplant. Thank you very much.
Thank you, sir. I could see Dr. Pamecha agreeing to everything. I mean, he was nodding his head in affirmation with what Dr. Acharya said, but you have about 45 seconds for rebuttal, since it's a debate. Dr. Pamecha.
Yeah. So, yeah, I agree to disagree a bit with Professor Acharya. I must say he's done a very nice presentation and he has got extensive data and experience. I'm too small to actually protest with him. But one thing we need to be in terms of what is happening here is with this step-up approach, what people, it has gone into practice that even with severe liver disease decompensation, people are trying to do stents and tips and all. And this patient get disbenefited from those treatment actually. So as Dr. Acharya has already produced a score, and it really clearly shows that there are patients actually who are not benefited with this type of treatment. They should be upfront offered transplant rather than actually being pulled into the cycle of intervention procedures. And these intervention procedures are not cheap. They are very costly as well. And patients spend a lot of money and time. And at the end of the day, they land up with transplant. So I think the treatment strategy should be individualized in patients. And it should not be a salvage transplant always. There are patients and a good group of patients who actually need upfront transplant.
I think, Dr. Acharya, any final comment?
No, for not final comment, Dr. Pamecha, what you were trying to say, I said the same thing. Yeah. You say bad liver disease, child C patients who have been unsuccessful by endovascular interventions will do bad. This is select, this is clear. There is no confusion. But if endovascular intervention is successful, more than 70 to 80% will improve. 20% will not improve. That is true in liver disease in life. Any disease, hepatitis B, if you see antivirals with MELD score more than 22 or 18, doesn't work. MELD score below 18 works.
So, sir, the question basically is that in your eyes, do you think there is a sub-selection of cases which can go directly for liver transplant? Or you think everybody has to go through the stepwise approach?
No. There is a subgroup of patients who can be subjected to transplant. For example, Dr. Goenka, if you have a diffuse hepatic vein obstruction with long IVC obstruction, and has a child, he is yellow, his kidney is hovering, his sodium is tottering, in such a patient, it's like reversing cirrhosis.
You're being very mean to Dr. Pamecha. You want to give very, very sick patients to Dr. Pamecha.
That's exactly what I am saying, that it's like, you know.
But that sick patient will come.
Piyush, Dr. Piyush, any comments from your side as a chairperson?
The transplant has its own problem because the DDLT is more better as far as transplant is concerned for this thing. LDLT has its own challenges, reconstruction of IVC grafts.
No, not really, because I think Dr. Gupta has published from India as well in terms of doing LDLT for bed carry, and there are good results. The technical challenges have been overcome, and you can replace the IVC and you can do the outflow reconstruction, nicely. It's not means that's not a contraindication in terms of this.
Not a contraindication in terms of complications and outcome.
Complication outcome, we have shown the data that the long-term outcome, short-term, long-term outcomes are very good even with this bad patients who have been referred for transplant. So what we are looking at transplant data currently, the results which were shown by Dr. Acharya as well and by me as well, that the long-term outcomes are very good even in those patients who have been referred with very advanced cirrhosis and with acute liver failures. So there is no confusion on that.
For fulminant hepatic failure, sir, what would be your take, Dr. Acharya, sir?
You see, for fulminant hepatic failure also, if you see the guidelines, if you have a fulminant hepatic failure, particularly they will occur in hepatic vein thrombosis. You have seen that. And that will happen in acute hepatic vein thrombosis. Okay? When there is an acute hepatic vein thrombosis, there is always a room for recanalization, doing a thrombus removal and anticoagulation, using various anticoagulants, you know that. Even intravascular anticoagulation. If salvage is not possible with that, then only transplant. That is the guideline. If you see the APSL guideline, which is published in Hepatology International in 2021, exactly gives it. But fulminant liver failure, blindly you should not subject to transplant. These are young people. And you are subjecting to liver transplant blindly, then half of them, more than half of them, are salvageable by endovascular stent.
I think in the interest of time, we'll have to close this debate, and I would request Professor Eapen to start the second debate. Thank you, both the speakers.
Thank you. Thank you, Dr. Goenka.
Thank you. We had a very interesting debate, and we have the next debate topic. May I actually invite Dr. Piyush Ranjan to invite the speaker to take on the topic, please. Piyush.
So the second debate we have, a very interesting one, beta blockers, we all know are the cornerstone of treatment of portal hypertension. And recently, after this 2010 hepatology paper, we have this concept of window period and this side effects of concern about the adverse events of beta blockers. So may I invite Dr. Akash Shukla, who is the professor and head of Department of Gastroenterology, SAT GS Medical College.
I think Dr. Raja was supposed to speak first, or what?
Dr.
Yeah, hi everyone. I think I'll be speaking against. So
yeah, I think like Dr. Kasher Raja from Bangalore first speak.
So Dr. Kasser from Bangalore.
Yeah. Thanks, Piyush. Let me share my screen. Wait a second. Yeah. So thank you, Piyush, and thank you, organizers, for this debate. So why this debate, first of all? I mean, as Piyush has already briefly introduced, that non-selective beta blockers are well-established drugs for prevention of both initial bleeding and recurrent gastroesophageal varicose bleeding in cirrhotic patients. And it's the cornerstone of treatment for varices and is actually the standard of care. But there have been studies after that 2010 study that non-selective beta blockers can have a detrimental effect in a subset of patients, especially those with advanced liver disease, severe decompensation, and especially refractory ascites. Now, whether these non-selective beta blockers are deleterious in advanced liver cirrhosis is not yet resolved, and I don't think we'll be able to resolve it after this debate also. The main reason is that there are very few good quality studies and very, very limited randomized control trials, with which the data, whatever we have, has a lot of individual bias and institutional bias. Now, propranolol has been there since 1980. This is a very landmark paper by Librek et al., who is the kind of the, you can say their group is the father figures of portal hypertension treatment beta blockers. And in 1980 Lancet paper, they said that if you reduce the baseline heart rate by 25%, you have a significant reduction in portal pressure. And that is how it all started. You know, researchers working under the same group under Professor Librek then looked at their data in the earlier part of this century and finally published a paper in 2010 in Hepatology. This is a single center study. We have to be very careful of how we interpret this study. So they had about 115 patients, moderate mild, about 19 was the mild. All patients were having refractory ascites. They were receiving large volume paracentesis and albumin replacement. Half of them were on Inderal or propranolol. Now, when they looked at their survival, they found that patients who were on propranolol had a median survival only 5 months compared to those who were not on propranolol. Mind, these groups were equally balanced. The 1 year survival was only 19% non-selective beta blockers versus 64% on patients who were not on non-selective beta blockers. Now, they looked at the various indicators of mortality by multivariate analysis. Of course, child C-class, presence of hepatocellular carcinoma, these are well-known risk factors for mortality. But treatment with beta blockers itself was an independent predictor of mortality. Now, very important to see, they looked at refractory ascites. In those patients with refractory, so overall refractory ascites was a risk factor for mortality. But in that category also, those patients who had renal impairment, so those patients who had a creatinine more than 1.5 or hyponatremia, sodium less than 130, were at higher risk for mortality. So these are important things because these will be discussed again and again. Now, the same group, probably they've been doing a lot of work on portal hypertension. They presented interesting data on a small group of patients, those who are undergoing large volume paracentesis. What happens to the post-paracentesis circulatory dysfunction? So in this first graph, we have patients who are on beta blockers. On beta blockers, as you see, their plasma renin activity goes up and remains elevated till day 7. In the same group, when you do the crossover, stop the beta blockers, they have reduction in plasma renin activity day 7. That is how we define post-paracentesis circulatory dysfunction. So what they imply is that patients on beta blockers, if they have large volume paracentesis for refractory ascites, they tend to have more post-paracentesis circulatory dysfunction. Now, the whole issue is summarized in this cartoon. Non-selective beta blockers are good. They reduce portal pressure. They reduce risk of variceal bleeding. They reduce bacterial translocation. They also have some effect on immunological function. But the main problem is to do with cardiac output. They eventually work by decreasing cardiac output. You can decrease cardiac output to only a certain extent. Once you decrease cardiac output beyond a certain limit, then you affect renal perfusion. So renal dysfunction happens, and that is what we do not want. Now, another interesting data is looking at cardiac index and mean arterial pressure and survival. Those patients who have a baseline low cardiac index, less than 1.5, or a mean arterial pressure less than 80, these are all landmark papers, they will have a poorer 1 year survival. So obviously in this group of patients, you can't be using beta blockers because you will further deteriorate the cardiac index and mean arterial pressure. And we obviously know that whether the cirrhotic patients are hypertensive or normotensive, they will reduce cardiac index in these patients. Now, these are our recent studies. So in between, there were a lot of observational studies which said that these data has to be taken with a pinch of salt. But recently, in the last couple of years, this is a study which looks at short-term hemodynamic effects of beta blockers in patients with decompensated cirrhosis. So what they've done is they've taken cirrhosis with high-risk esophageal varices with or without ascites. So there are decompensated patients, about 190, and there are compensated patients, about 213. And they have looked at systemic parameters and hepatic hemodynamic measurements before starting beta blockers and 1 to 3 months after starting beta blockers. obviously decompensated cirrhosis will have higher HVPG and hyperdynamic circulation compared to compensated cirrhosis. But what they found is that in the decompensated cirrhosis, there is lower reduction in portal pressure compared to the compensated cirrhotic patient when you give them beta blockers. At the same time, there is greater reduction in cardiac output. So you are having more problems with cardiac output and lesser benefit on the portal pressure. And when they looked at decompensated patients who died compared to those who did not die, there was a greater decrease in cardiac output in those patients who died. So I think the marker is cardiac output. If we in future trials, we have to study whether beta blockers are detrimental or not, we have to see what is exactly into the cardiac output. And this we are not looking at when we do clinical things. Now, cardiac output under beta blockers independently predicted death. And death was obviously higher in decompetent patients with cardiac output less than 5 liters compared to those who had higher cardiac output. Now, another thing which has been looked at is patients who developed SBP. If these patients are continued on beta blockers, there is a study which has shown that if you continue them on beta blockers, in the next 3 months, there is a higher risk of developing HRS and acute kidney injury, but not in the long term, obviously because patients have a bit of recompensation later on. Now, this is a study which has looked at, is there something to do with beta blocker dose? So, we don't use that high doses of beta blockers in such sick patients, but obviously if you use high doses of beta blockers, you will have higher mortality, which is expected kind of. So in patients with refractory ascites with or without SBP, higher doses more than 80 milligrams are associated with higher mortality and higher risk of HRS. And interestingly, in this study, low dose of beta blockers found to be actually beneficial in this high-risk patient compared to not usage of beta blockers or no beta blockers. Now, this is another interesting study. This is also a very recent study. I was unable to get the full text, but still whatever I could make out of it, that in these patients, they have looked at whether beta blockers impair global circulatory homeostasis and renal function in, again, patients with refractory ascites, which is our main group. So they looked at left ventricular systolic function and renal perfusion 4 weeks after starting non-selective beta blockers. And left ventricular systolic function was markedly diminished in patients with refractory ascites, but not in the patients who had diuretic responsive ascites. But look at that. Renal perfusion pressure was reduced in both groups, but left ventricular systolic function was markedly depressed in those who had diuretic refractory ascites. So the authors tried to sum up that, obviously there's a compensatory mechanism of cardiac contractility and renal perfusion. The cardiac contractility, because the hemodynamic response, increases as the patient progresses in his disease course. And the renal perfusion gradually goes down. At a certain stage, cardiac contractility will fall down because the compensatory mechanism will not be able to take care of the balancing function. At that stage, if you give them beta blockers, further decrease the cardiac contractility, you might go below the critical threshold of renal flow autoregulation, and then you might have renal dysfunction. So this is a very nice way of explaining that there is some point beyond which beta blockers cannot be used. So these are the problem areas: refractory ascites, renal dysfunction, low mean arterial pressure below 80, patients with SBP, severe hyponatremia, which is an indirect marker of overall hemodynamic status, of course, high MELD score, and something about cirrhotic cardiomyopathy. Again, I'm not going to discuss a lot about cirrhotic cardiomyopathy, but here also, we are not assessing all patients with cirrhotic cardiomyopathy. And probably if patients are in borderline cardiac function, beta blockers might be detrimental. Now, I'm sure Dr. Akash will refer to this study. In this study, these are patients listed for liver transplant who have ascites and are on beta blockers. And the patients who are on beta blockers actually had better survival while waiting for transplant versus patients who are not on beta blockers. But these patients are very select group. If you look at that, very, 2.5 month follow-up, the MELD score is 16, 17. We hardly transplant patients at MELD score of 16. So these are fairly reasonably preserved patients. Sodium levels were not low. Their sodium levels were like 130. And interestingly, the blood pressure records were not available in this study, hardly in 1/4 of patients. And even in those patients, the systolic BP was quite good. So obviously, these patients will tolerate beta blockers. We should not stop beta blockers in this group of patients. And of course, they had no cardiac disease, but because they are all evaluated for liver transplant, cardiac disease has been excluded. And once again, the dose of beta blockers used was small. So now come to the window hypothesis, which Piyush also mentioned in the beginning, that initially, when you have early cirrhosis, your cardiac reserve is very good. The sympathetic nervous system and the renin-angiotensin system is not very much activated. And we wonder whether beta blockers are really useful in this period, at least for management of the hemodynamic and the cardiac output, as well as reduction in portal pressure. So this window, maybe beta blockers are not that much useful. However, as the patient develops varices, has early decomposition, we know that beta blockers are effective because they will reduce portal pressure, they will reduce variceal bleeding. But once the patient progresses further and the cardiac reserve starts decreasing, it is here where the detrimental effect of beta blockers might be experienced. So once again, if you look at what people are recommending, early cirrhosis, probably beta blockers have no effect on survival. Here, these patients have good quality of life, and beta blockers might actually hinder their quality of life. So we have to be careful, not push these patients to have high doses of beta blocker. In the decompensated cirrhosis group, of course, they improve survival by reducing variceal bleeding. No doubt they should be used. But in the end-stage cirrhotics, there might be a detrimental effect, negative impact on cardiac reserve, and decreased perfusion to the other organs. So this is the ASLD, slightly old but still relevant, that once patients do not have varices, they have low portal pressures, then non-selective beta blockers are mostly ineffective in this substage. Although there is new data that they might actually be effective in a small subset. When they have varices, of course, beta blockers are effective. And of course, when they are decompensated, as I said, beta blockers have to be carefully considered. Now, the ASLD, recent guidelines, they are as confused as what we will be. Controversy persists regarding use of non-selective beta blockers in refractory ascites. They do say that refractory ascites is not an absolute contraindication, but there are absence of randomized controlled trials. Caution has to be used when you're using patients beta blockers in refractory ascites, especially in those with low systolic blood pressure less than 90, hyponatremia less than 130, or elevated serum creatinine. I think we can discuss a bit about what low systolic blood pressure means, because some people have quoted a mean arterial pressure of 80 or 82, and here they've quoted low systolic blood pressure 90. 90 would actually correlate to a mean arterial pressure of less than 80. So this fact is again not very much clarified in the literature. In patients with SBP, non-selective beta blockers should be avoided, again, if you have low mean arterial blood pressure. Of course, once the patients improve, beta blockers can be reintroduced. Now, we have to understand that there are obviously quality of life issues. So beta blockers, when you give them, especially in the early phase of liver disease, we have to understand that there are patients who do not tolerate it due to adverse effects. There are very few quality of life studies of beta blockers in early cirrhosis, and conditions and symptoms like fatigue, decreased exercise capacity, sexual dysfunction are often ignored. And of course, there are cardiac adverse effects, and the fact about cirrhotic cardiomyopathy also remains. So to conclude, the decision to utilize non-selective beta blocker must carefully balance the risk and benefit in advanced cirrhosis. And patients, even if you're keeping them on beta blocker, you need to continually assess them because the indications might change. And consider stopping non-selective beta blockers in patients with low mean arterial pressure or a systolic BP of less than 90, hyponatremia, renal insufficiency, obviously ongoing infection, or refractory ascites requiring frequent paracentesis. We can debate this, after Dr. Akash presents his data. And most important to remember that even if we are continuing refractory ascites, we have to understand that the mortality benefit of non-selective beta blockers in refractory ascites the data is very limited. So if we have, let us say we have already controlled the varices by bending, and we think the patient is low risk for bleeding, then do we really need to continue non-selective beta blockers in patients with refractory ascites? With that, I would like to end. Thank you so much.
So we have heard Dr. Kasser's point on this. So now may I invite Dr. Akash for his talk on beta blocker would work only during the window period. Again, he will be speaking against the motion.
Thank you, chairpersons. At the outset, I would like to thank Inasl for giving me this opportunity, and thank you, chairpersons and moderators, for the session. And thank you, Kaiser, for setting the ball rolling. In the next 10 minutes or so, I'll take you through why I am speaking against the use of beta blockers only during the said window period. The first problem is whenever you open a window and make your first step in the world, you may actually fall if you have not assessed the global situation or what is beyond the window. So we need to first understand the whole sum before we describe a window or walking out of the window. So we need to broaden the vision and then deepen the roots of knowledge to understand where we can use beta blockers in our population. So this was the first paper which looked at, way back in 2013, which showed that in patients with refractory ascites requiring repeated large volume paracentesis, use of propranolol is actually associated with a better survival. And this was another paper which actually came after the concept of window period came into being, where they looked at the competing risk analysis for death or transplant in patients with or without non-selective beta blockers in transplant waitlisted patients. And I agree with Dr. Kaiser that at the time of listing or at the time of inclusion of the patients, most of these patients had an average MELD score of 16 to 17. But that is when you should be listing your patients for liver transplant. And most of them have an average period of 6 months to 12 months before they can be transplanted. So in this group of patients, more patients reached the stage of transplant and more patients survived without a transplant when they were given beta blockers. Similarly, in the subgroup of patients who had refractory ascites in the same study, which Dr. Raja very conveniently omitted, they showed distinctly that those with refractory ascites also have a survival benefit, just like those without refractory ascites. And I know the next criticism was that it was a small study. So to quote a large study of almost 3,719 patients who had a history of therapeutic paracentesis, 3 groups of patients, mildly decompensated, severely decompensated, and patients with a history of SBP, they were evaluated, and across the groups, there was a significant improvement in those patients who had been treated with beta blockers. Now, very interesting finding of this was the dosage of beta blockers which was being used. So in those who were mildly decompensated, patients who were given a beta blocker dose or propranolol dose of more than 160 had worse outcomes, whereas those who were given up to 160 milligrams, they actually had better survivals as compared to no propranolol. Similarly, in patients with severely decompensated cirrhosis, those patients who were given more than 160 milligrams of propranolol per day had a worse outcomes. Patients with 80 to 160 had the best outcomes, and those with less than 80 milligrams per day actually had moderate outcomes, but were still better than no propranolol. So the key thing is to use the right dosage. Unfortunately, because it was considered as a treatment for portal hypertension, before this study, in the West, the propranolol was used as a drug for treatment of worsening portal hypertension. And with the worsening of the portal hypertension, a higher dose were being used. And that is what unfortunately led to a lot of adverse outcomes. Whereas after this study, we realized that what is the right dose? I don't remember a single patient where I have used a propranolol dose of 160 milligrams per day or more. Similarly, this was a post hoc analysis of the 3 cetabaptan trials, and which showed that the all-cause mortality with NSBB use was better as compared to no NSBB, both in all patients as well as those with refractory ascites. So if you're using the right dose, then you'll get good results. But if you use extra force, like it used in this scene, obviously there'll be chaos all around, and you'll have tables and chairs crashing, and you'll have adverse outcomes. In this paper by Bozon, published in Hepatology 2016, again, they showed that those patients who had a good mean arterial pressure, like Dr. Kaiser referred to, had a better survival chance with use of non-selective beta blockers. The best outcomes were in those who were given, who had a mean arterial pressure of 81 to 90. Now let's see whether we can expand this window or do we have other windows. So coming to the sick cirrhotics, those who are admitted for whatever reasons. So in this elegant study, 3 groups of patients with varices and ascites, and with ascites alone. When they compared those patients in these 3 subgroups, whether they were given beta blockers or not, and what were the outcomes, the only predictor of in-hospital survival on multivariate logistic regression analysis was beta blocker, as you can see distinctly here. And the MELD score was associated with mortality. So these were the 2 things which were the most significant. So we can say for sure that beta blockers may be continued in the right subgroup of patients who are admitted for different reasons. When they looked at the subgroups, across the subgroups, whether the ascites was mild or severe, whether the combination of varices and ascites was mild, severe, or all-cause ascites, the difference in outcomes with beta blocker was superior. When we looked at the data with the newer drug, carvedilol, again, in patients with all cause of ascites, all severity of ascites, use of carvedilol was associated with improved survival. In fact, in patients with mild ascites, the use of carvedilol was associated with 43% reduction in the mortality. And I agree with Dr. Raja on this, that systemic arterial blood pressure is a very important parameter. And it is not the window, but the systemic arterial pressure and the hemodynamics which should determine which patients should undergo beta blocker therapy and not. So this paper showed that the 28-day liver transplant-free survival after the first paracentesis was better in the patients who received NSBB. If you look at the patient who had a mean arterial pressure of less than 65, the survival was equal, but not worse. And in those who had a mean arterial pressure of more than 65, use of NSBB resulted in better survival. Let's see in those patients with SBP in the same study. Use of NSBB was associated with a better survival. Again, when you look at the subgroups of those with a mean arterial pressure of less than 65, there was no benefit with NSBB, but it was not detrimental. Whereas when you look at the patients who had a mean arterial pressure of 65 or above, it was associated with a marked improvement in survival. Let's go to another group, ACLF with NSBB. Use of NSBB in patients with ACLF was associated with improved survival. And surprisingly, this was irrespective of the mean arterial pressure at the baseline. Those with less than 65, as well as those with a mean arterial pressure of 65 or more, had a survival benefit. This was the canonic study by Mukherjee et al., which looked at 164 patients with ACLF who received NSBBs and 185 who did not. And they showed a survival benefit in those where NSBBs were continued as compared to those patients where NSBBs were discontinued. The peak benefit was in the patients who had a CLIF ACLF score between 30 to 65 to 70. And that is where actually we need to intervene. If you look at the improvement in the grades of ACLF, more patients with NSBBs had improvement in the ACLF grade as compared to the patients who were not, and less patients who had received NSBBs had a worsening as compared to the group of patients who did not receive NSBBs. Without going to the details of this graph for want of time, resolution of ACLF was inferior in patients who did not receive NSBBs as compared to patients who got NSBBs. Similarly, worsening of ACLF was more in patients who received no NSBBs as compared to those who got non-selective beta blockers. And the comment on this, the editorial comment on this paper was by Garcia Tsao, and she says the window reopens. And she commented on the innovative investigator outlook beyond the portal pressure reducing effect of NSBBs and postulated the immunomodulatory effect in reducing the bacterial translocation, sympathetic nervous system activity control, and accelerating the intestinal transit. This was another study from India, which looked at the use of carvedilol in patients with acute and chronic liver failure. And again, these were the patients who had no or small varices at presentation. And they showed that there was a survival benefit when these patients were treated with carvedilol. Very similar studies to the...
Akash, you'll have to wind up now.
Yeah, I'm finishing, just 2 slides more. So just very similar data to the Western type of ACLF in an Eastern ACLF population. So very similar outcomes, and the mechanism was correlating with the fall in the HVPG. My friend talked about left ventricular diastolic dysfunction, and this study showed use of carvedilol along with the ivabradine improves the left ventricular dysfunction. In fact, there is a survival benefit with carvedilol alone, and even more survival benefit with the combination of carvedilol and ivabradine. All the events reduce once you use this combination. So the mechanisms have already been discussed about the use of non-selective beta blockers, which are well known, but the additional benefits could be because of the improvement in congestion or ischemia of the gut mucosa, decrease in the intestinal permeability, alleviating the systemic inflammation, shortening the prolonged QTC interval, And also, we know now that there's emerging evidence that they may reduce the incidence of hepatocellular carcinoma. So there is not a single window, but several windows that we are now seeing, including refractory ascites, ACLF, patients awaiting transplant, spontaneous bacterial peritonitis, and the mechanisms. The road to the future is by working on how does it reduce inflammation, how much does it reduce inflammation, and how does it reduce the HCC risk. Thank you very much.
So we have some time to Dr. Raja for rebuttal. Dr. Raja?
Yeah, thank you, Dr. Goenka. I mean, there are studies on both the aspects. There are the people who work on the hemodynamics who say that beta blockers are detrimental. Their main logic is that it is detrimental to the renal perfusion and the effects on the kidney. So most of these studies, agreed, they have shown some settlement, but if you go into the details of study, they are all observational studies. They have retrospectively looked at data. Even the ACLF study from the caninic study was never designed to look at beta blocker effect. They have taken out the data and then analyze it. Definitely, there will be some benefit if we were to do a prospective trial. Then only we'll get the real results. But the main thing what we have to decide is that what are the limits where we have to stop beta blocker. For example, now we are having conflicting views with 80 millimeter mercury of mean arterial pressure was kind of sacrosanct. Okay, we stop it below that. Now we say 65 is also enough. So are we really willing to treat patients with 65 mean arterial pressure with beta blockers? At this, we actually say we have to maintain arterial pressure at 70 in these patients. So how can you give beta blockers at 65? So things like that. And plus patients who are having severe renal dysfunction, creatinines more than 1.5 or GFR less than 60 or 50, should we be giving that in that group? So even I'm not clear, but at least these are the areas that I would stop beta blockers. In general, definitely we would get beta blockers in the majority of the patients. And also one more thing, the window keeps on opening and closing. It's not that once you stop beta blockers, you cannot restart beta blockers. So the window can reopen once your patient stabilizes.
So do you both agree, Dr. Raja and Dr. Shukla, that it's the dose which matters? Say, if you control the dose well, then there's no window period. Akash?
Sir, I agree that there are some absolute no's. I agree with Dr. Raja that there are certain patients where you would definitely not use in somebody who has got a very high creatinine and a very low mean arterial pressure. But I think we should not just confine ourselves to the conventionally thought of window, but we should widen the horizons. And I agree with you completely that the dosage is very important. So is the monitoring. I've seen that very often it's a fixed dose which is given to the patients, and that doesn't help. So it's a continuous process of monitoring, being actively involved in the management, continuously looking at the hemodynamics, and that is what is going to tell us, give us the maximum benefits with the use of beta blockers.
So the golden question, Akash, is that how do you monitor them? They are on your OPD basis. So you cannot be asking them to check their blood pressure regularly at home. How do you monitor them?
So, sir, actually, we actually do that. So we ask the patients to at least monitor their blood pressure once a week at home also. And every time they're coming to a visit, we should measure their blood pressure and calculate their mean arterial pressure. This is something which we have been doing for now over 10 years. And I think that is something that has to be done to give these drugs effectively and safely, more importantly.
So, Dr. Piyush, Dr. Ipan?
This window concept holds for both non-selective beta blockers and carvedilol as well. There is less data with carvedilol, but carvedilol to the same concerns apply.
So actually, the data with carvedilol is actually much more as compared to with propranolol in terms of expanding the indications of therapy. So like the ACLF data is almost exclusively with the recent one is with carvedilol. Similarly, in patients with refractory ascites, we know that up to 12.5 milligrams per day, there is hardly any drop in blood pressure or mean arterial pressure. So that is why in the right dosages, as Dr. Goenka said, we should prefer to use carvedilol rather than using propranolol.
This propranolol is predominantly metabolized by liver. So as the child score progresses, we should be reducing the doses of propranolol accordingly. So in a child, elevated child B or child C cirrhotics, probably we should not be using more than 80 milligrams of propranolol.
Yeah, you're absolutely right. We rarely go beyond 80 milligrams. I remember very rare patients who have gone up to 120, but I've actually personally never used 160. Most of my patients do not tolerate a dose of beyond 80. They will develop bradycardia or hypotension with a dose beyond 80. Occasional patients have tolerated dosages up to 120. I don't know, Dr. Raja, can you share your experience on this?
Yeah, I mean, I agree with that. I find it surprising when someone says my patient would take 80 milligram twice a day. You know, the max, most of us would agree, would be like 40 BD. Maximum would be 60 BD in an isolated patient who is like child A and majority is portal hypertension. I think one more thing about the window is the other end of the window. You know, like what is your opinion regarding the earlier part of cirrhosis? And we have had this timolol trials and all those things which have never really supported the use of beta blocker and pre-primary prophylaxis or small varices which would not bleed. So in that group, I know there are some new studies which are now coming up that beta blockers would have benefits beyond the portal hypertensive, like immunomodulatory infections, intrahepatic vascular resistance and things like that.
So yeah, thank you, Kezer. I think that is a very valid point. But unfortunately, the data so far is extremely weak. That is why I didn't touch upon the first half of the window or the earlier part of the window, because there, unfortunately, with the use of beta blockers, you may actually hamper the outcomes without having any benefit. Whether it is a study from Dr. Sareen published in 2013, J. et al., or we look at the other data from Europe, even the data from Paris, Clichy, they showed that there was no benefit in patients in the primordial prophylaxis or before the primary prophylaxis. So I think that is why it has not taken off. And except for that study of timolol, I think one study with timolol which showed some benefit, other studies with timolol have not shown any benefit. So I think that is, I think, too premature to talk about opening window on that side, the earlier.
Pathophysiologically, the early part of portal hypertension is driven predominantly by intrahepatic resistance, and non-selective beta blockers do not act there actually.
So there might be some role of carvedilol rather than non-selective beta blockers.
And if you look at the non-selective beta blockers in early part, the mechanism of action is such that it may actually increase the mean arterial pressure because of unopposed systemic alpha adrenergic effect.
Yeah, Piyush, I agree. And even if you look at the ASLD guidelines, the recommendation in the earlier part is if you have to use it is carvedilol rather than propranolol, yeah, or nadolol, yeah.
So, Dr. Ipan, any concluding remarks? Dr. Goenka, with your...
I think we had two excellent debates, and we have gone beyond the time. So thanks all the speakers and of course the co-chairpersons. I think we'll wind up. Any comment from Dr. Kaushal Madan if he's around? Because this seems to be the last session today.
No, thank you, sir. Thank you very much. Kaushal is in the other hall. I'm
okay.
Pankaj here.
Yes, Pankaj.
And thank you so much for everything. If there are any comments from the chairpersons before we wind up?
I think it's time for the dinner for everybody.
Okay. Thank you, everybody. And thank you for such an exciting show. And we look forward to seeing all of you tomorrow. And we have a wonderful fair tomorrow lined up. In Hall A, besides the plenary session, we will also have the orations. And we have a session on contemporary hepatology. Besides the posters in Hall B, we'll have specific case-based panel discussions on the timing of transplantation, the kidney transplantation. And on Hall C, again, we'll have case-based panel discussions on DILI as well as on ACLF. Besides that, there's a keynote address on liver transplantation in the long-term management. Look forward to seeing all of you there tomorrow. See you. Thank you very much.
Good night.
Good night. Good night.
Thank you. Good night.